Hello, Baccho. Good evening to all of you. Hopefully, the audio visuals are fine. Let me know in the chat box if the audio visuals are clear. Shall we start with the session? Are the audio visuals fine? Let me know in the chat box. Great, great. Chalo. So let's start. Let's cover all the question in today's session. So bear with me for the session. One thing. Second important is today also we will cover the most important high yielding and the repeated topics in the FMG and EPG examinations from surgery, so that the probability of the questions would be higher in the examination. Clear? We will be definitely discussing all the related and the allied topics for the questions we are discussing. That is one thing to be remembered. And secondly, make sure you share this with your friends also. So whatever is given over here, basically they are also, like, obviously, as I always say, it is a qualifying examination to support each other. And in the last few days now, so once you're confused, so definitely just make sure that you revise all these topics thoroughly and things will be done. Okay, chalo. So let's start without any further delay now. Now, the first one that we have to discuss is this question number 31. In last video, in yesterday's video, we have discussed about 30 questions. So now let's begin after that. Here we are having a 50-year-old patient who came to us with a history of trauma or a history of fall 3 weeks back. Now presents with symptoms like confusion and ataxia. He is on treatment of alcohol dependence and his last intake was 2 weeks back. So NCCT scan reveals the following finding. What is the likely diagnosis? So if you see here, this is the classical picture of a NCCT beta, and on NCCT we are able to see, here we are able to see something appears more black or there is a hypodensity. I have always been telling you that NCCT pe, whenever a patient of head trauma or whenever a patient of head injury comes to you, please remember on the NCCT head there are going to be two possibilities. That means either something appears more black or something appears more white. If something is appearing more white, we know we call it as hyperdensity, and hyperdensity is basically suggestive of an acute bleed or acute hemorrhage. Hyperdensity is usually suggestive of acute bleed or acute hemorrhage, whereas if something appears more black, that is known as hypodensity. If something is appearing more black, that is known as hypodensity, and that is suggestive either of a chronic bleed or a chronic hemorrhage, or secondly, it is going to be suggestive of an infarct. Either it is suggestive of a chronic bleed or a chronic hemorrhage, or it is going to be suggestive of an infarct. These are the two things. So here definitely they are saying one thing, that the patient had a history of trauma. And if you see at the NCCT, you are able to see a concavo-convex or a crescentric hypodensity. We know hypodensity on the NCCT is usually suggestive of chronic hemorrhage or an infarct. If you think about both the condition, the more likely case will be a chronic hemorrhage or chronic bleeding, because there is a history of trauma. So as there is a history of trauma, we will think about chronic hemorrhage or chronic intracranial hemorrhage as the likely cause. And we know which intracranial hemorrhage shows you a concave or convex or a crescentric hyperdensity or hypodensity. We know it is nothing else but option B, that is SDH or the subdural hemorrhage. So this is a classical case of a chronic SDH or a chronic subdural hemorrhage beta that has to be kept in mind. Clear about this? Was a recent EPG question. Okay, instead of hyperdensity, they have shown you a hypodensity. So if there is a history of fall, okay, and after 3 weeks, if the patient comes to you and the NCCT head shows you a concave or convex or a crescentric hypodensity, please think about a case of chronic SDH or a chronic subdural hemorrhage. We know EDH or extradural hemorrhage, it is commonly an acute condition. Patient doesn't present as a chronic case, okay, more commonly. Second, extradural hemorrhage mein there is a biconvex or a lenticular hyper or hypodensity. Clear? Next is option C, that is intraparenchymal hemorrhage. We know that is bleeding within the brain parenchyma or bleeding inside the brain tissue. Do remember that may happen due to trauma, but important is in that condition there is a hyper or a hypodensity seen inside the brain. Okay, most commonly at the level of putamen. Sarkari question: commonest site for hemorrhagic stroke or intraparenchymal hemorrhage? Answer is going to be putamen beta. Whereas next one is going to be subarachnoid hemorrhage. Do remember subarachnoid hemorrhage mein patient basically comes to you with complaints like thunderclap or a worst headache along with nuchal rigidity. These are the symptoms, and the NCCT head classically shows you that star of death appearance, right? Now, important is, so here it is more likely a case of chronic subdural hemorrhage. Do remember, this is the classical picture where you are able to see there is a biconvex hyperdensity or a lenticular hyperdensity. We know biconvex or a lenticular hyperdensity is a classical feature of nothing else but EDH or extradural hemorrhage. And we know extradural hemorrhage, which is there, it is going to happen after a significant trauma, and after that the patient becomes unconscious, regains the consciousness, again becomes unconscious. So that period of consciousness between two period of unconsciousness is classically called as lucid interval. So do remember, lucid interval is a classical feature of EDH or an extradural hemorrhage, and the commonest vessel to bleed in patients of EDH or extradural hemorrhage is the MMA, that is middle meningeal artery, is the most common vessel to bleed in EDH. Whereas if I talk about this picture over here, here you can see the NCCT head is showing you a concavo-convex or a crescentric hyperdensity this time. And we know whenever there is a concavo-convex or a crescentric hyperdensity, it is a classical feature of SDH or a subdural hemorrhage. Yes, this is going to be a picture of an acute SDH or a acute subdural hemorrhage beta. And here you are able to see there is a concavo-convex or a crescentric hyperdensity. Important is SDH usually happens after a trivial trauma, especially they will give you a case of an elderly patient who had a history of fall. Elderly patient, history of fall from chair or history of fall in bathroom, very classical. And do remember, the most common vessels to bleed in patients of SDH or subdural hemorrhage are the bridging emissary veins. So bridging emissary veins are going to bleed in patients of SDH or a subdural hemorrhage. Hopefully clear. Whether it is a case of EDH or a SDH, in both the conditions, do remember one point: whenever the hematoma is very small and the patient is asymptomatic, management is conservative. But if the hematoma is big in size, usually volume more than 30 cc, or the patient is symptomatic, we tend to go for surgery like a craniotomy surgery or a burr hole surgery. And I hope all of you are quite aware, in patients of EDH, when we do a burr hole, the surgical landmark is going to be pterion. Commonly we prefer craniotomies, but some cases mein burr hole can be done, and for that the surgical landmark is pterion. Hopefully clear. Next is question number 32. You are able to see a female patient who came to us with complaints of varicose vein. Now presents to us with complaints like pigmentation along with eczema, and there is fat loss over the same region. Okay. Now, as you are able to see here, there is pigmentation, there is eczema, and there is fat loss also. What is the stage of clinical classification of this according to the CAP guidelines? I hope all of you are quite aware that whenever a patient of varicose veins comes to us with these kind of features, so you are able to see this is a classical condition of nothing else but LDS, also known as lipodermatosclerosis. Yes, so in patients of varicose veins, whenever there is going to be fibrosis of the skin as well as the fatty tissue, we know that is called as lipodermatosclerosis, giving you a very classical appearance known as inverted champagne bottle appearance. So this picture which is shown over here, it is a classical case of lipodermatosclerosis, classically giving us the inverted champagne bottle appearance. That is what is important. And we know, if I talk about the classification of varicose veins. So we know the classification of varicose veins is known as CAP classification, where C basically stands for clinical manifestations, E stands for etiology, A stands for anatomy, and P stands for pathophysiology. Again repeating, C for clinical manifestations, E for etiology, A for anatomy, and P for pathophysiology. Now in this classification, remember the clinical one. First one, that is C0, means there is no signs of venous disease. C1, that means the patient is actually having telangiectasia or spider veins, that is veins less than 1 mm dilated, or reticular veins, that is veins 1 to 3 mm dilated. Second one, C2, that means varicose veins whenever the veins are going to be more than 3 millimeters dilated. Next, C3 is going to be edema, that is swelling which will develop. If I talk about C4, C4 is going to be the skin changes. Now in C4A, we are going to have pigmentation or eczema. C4A is basically pigmentation of eczema. C4B is lipodermatosclerosis or atrophy blanche. Do remember C4B is lipodermatosclerosis or atrophy blanche. C4C is corona phlebitictia. Okay, C4C is corona phlebitictia. C5 is going to be a healed venous ulcer. C5 is a healed venous ulcer, and C6 is an active venous ulcer. C6 will be an active venous ulcer. Now here they have asked us about the stage of lipodermatosclerosis, which was a PYQ in FMG. Do you remember this lipodermatosclerosis comes under the stage C4B of the varicose veins or the CAP classification. So we know the answer has to be option C. That is the stage C4B is lipodermatosclerosis beta. ठीक है so that is important. If there was a case of swelling, we would have called it as C3. If there was a pigmentation and eczema only, no fat loss or no inverted champagne bottle appearance, then answer would have been C4A. ठीक है. And if there was a healed venous ulcer, sorry, active venous ulcer, the answer was C6 then. So here, as I've already told you, varicose veins are nothing else but the dilated and tortuous superficial veins of the leg. So whenever the superficial veins of the leg are dilated and tortuous like these are called as varicose veins. We know varicose veins means whenever the veins are more than 3 millimeter dilated. The commonest cause for varicose veins is valvular incompetence. The most common cause of varicose veins is the valvular incompetence, especially seen at the saphenofemoral junction. Okay, valvular incompetence commonly at the saphenofemoral junction. Do remember the risk factor of varicose veins is prolonged standing. So yaad rakhna one thing, prolonged standing increases the risk of varicose veins, whereas prolonged immobilization increases the risk of DVT. Clear? We know that investigation of choice in cases of varicose veins is a duplex scan or a color Doppler. That one thing that we have studied in class a lot of times, that is what for all the peripheral vessels, investigation of choice is a duplex scan or a color Doppler, whereas for all the central vessels, the investigation of choice is a CT angiography. Hopefully clear. That is important. The best treatment that we have for varicose veins nowadays is nothing else but either a EVLT or a RFA. What is EVLT? It is an endovenous laser therapy. So nowadays we are going to collapse the junctions and the superficial veins with the help of laser. Okay, so obviously if the veins are collapsed, there is no pooling up of blood or no dilatation of veins over there. So that is EVLT or endovenous laser therapy. Another option is RFA or radio frequency ablation. Okay, the RFA is radio frequency ablation. Both are good treatments. Any one of them you can prefer. Okay. Next is question number 33. We are having the case where they say a patient comes to the casualty with complaints of a severe headache. His blood pressure was found to be elevated around 160 by 100 millimeters of mercury. CT scan reveals there is a subarachnoid hemorrhage. So they have clearly said that CT scan is showing you a subarachnoid hemorrhage beta. Now they are asking you what is the next step in the management of this patient. Please tell me the answer. What is going to be the probable answer for this? They are asking you the next step in the management of this case. Options are A is IV nimodipine, B is angiography, C is aneurysmal clipping, and D is fibrinolytic therapy. Let me know what is going to be the answer for this question. Now we know that subarachnoid hemorrhage or bleeding in the subarachnoid space which is there, whenever the patient comes to us with that, patient will have a classical two features. One is thunderclap headache, which is also called as the worst headache of life, and second is nuchal rigidity or neck stiffness. We know only headache and nuchal rigidity, think about a case of subarachnoid hemorrhage. If they say fever also, then think about meningitis. Secondly, do remember one of the leading causes for a case of subarachnoid hemorrhage is rupture of the barianeurysms, right? A spontaneous rupture of the barianeurysms will cause a subarachnoid hemorrhage, and the commonest vessel to bleed is the anterior communicating artery. The commonest vessel to bleed in subarachnoid hemorrhage is the anterior communicating artery. In cases of subarachnoid hemorrhage, if I do a NCCT head, you can see the NCCT head shows me a hyperdensity which looks like a star. So we know there is hyperdensity in the ventricles or in the sylvian fissure, also referred to as the star of death appearance. So subarachnoid hemorrhage shows me a very classical star of death appearance on an NCCT head. These are the important features that you have to keep in mind, beta. Now, if they ask you in this case, this was a PYQ in NEET PG. So if they ask you if a case of subarachnoid hemorrhage comes to us, obviously this seems to be a non-traumatic subarachnoid hemorrhage because they have not given any history of trauma in the patient, right? So in this non-traumatic subarachnoid hemorrhage, what should be the next step, anybody? So please remember, basically, yes, we will come to ulcers, don't worry about that. So answer in this question is nothing else but option B, that is an angiography to be done. Reason is whenever there is a case of a non-traumatic SH or a non-traumatic subarachnoid hemorrhage, we know it is basically due to the rupture of barianeurysms. So first of all, after doing NCCT head, first of all you should do a angiography or an angiogram. And once you have done an angiography or angiogram, beta, you have to decide, basically you have to go for a conservative management or a surgical management. In non-traumatic SH, do remember, after doing NCCT head, go for an angiography where you will be able to see the number of aneurysms, site of aneurysms, extent of aneurysms, everything. And based on that, we decide whether we should go for conservative or surgical management. If you decide to go for a conservative management, then we know the drug of choice for the conservative management of subarachnoid hemorrhage is nothing else but a calcium channel blocker known as IV nimodipine. Okay, conservative management के लिए the drug of choice is IV nimodipine. Whereas if you decide a surgical management, so we know surgical management is either do an aneurysmal clipping by neurosurgery or do a endovascular coiling. Okay, by an interventional, the interventional radiologist will help you basically to place a endovascular coil. So whenever we decide a surgical management, either we can go for aneurysmal clipping or endovascular coils, basically that is important. Fibrinolytic therapy are not indicated in hemorrhages. Fibrinolysis or thrombolysis is usually done in cases, beta, whenever there is a blockage or a clot. It is rather contraindicated in hemorrhages because the bleeding will increase otherwise. Clear about? So that is what is important to be remembered. Hopefully all of you got the answer for this. Now do not make a mistake. Clear? So that is what is important. Chalo. Next important, if I talk about, if it was a case of traumatic subarachnoid hemorrhage, do remember traumatic subarachnoid hemorrhage mein after we do a NCCT head and NCCT head confirms the diagnosis, we directly go for IV nimodipine. In traumatic subarachnoid hemorrhage, we don't do an angiography. In traumatic subarachnoid hemorrhage, we don't need any kind of clipping or coiling. Okay? In traumatic one, directly go for IV nimodipine. But if it is a non-traumatic case, first angiography and then decide whether conservative or surgical. Next is question number 34. Very easy and a commonly repeated topic. We are having a 23-year-old male patient who presents to us with complaints of a midline swelling in the neck, beta. Okay. Now we know midline swellings in the neck are more commonly related to the thyroid gland itself. The swelling moves with deglutition. Okay, this is a very classical feature. The swelling is moving with deglutition or swallowing, and the swelling also moves with protrusion of tongue. So the swelling moves with deglutition, and most importantly, the swelling moves with protrusion of tongue. Whenever you move the tongue, the swelling also moves. That means the swelling is somewhere connected to the tongue. What is the likely treatment they are asking you? So I hope all of you are quite aware. The provisional diagnosis of this condition is a case of a thyroglossal cyst. Whenever we know that the thyroglossal tract which is there, it is patent. In that there is collection of fluid over a period of time, and that leads to formation of a classical thyroglossal cyst. And whenever there is a thyroglossal cyst in the neck, it moves with deglutition as well as with protrusion of tongue. PYQ was what is the most common site? So yaad rakhna, the most common site for a thyroglossal cyst is subhyoid or infrahyoid. So subhyoid or infrahyoid is the most common location of the thyroglossal cyst, whereas If they ask you what is the investigation of choice, so we know as it is a collection of fluid or as it is a cyst, the investigation of choice has to be an ultrasound neck. Usually we go for an ultrasound neck. And the treatment, if they ask you, do remember the best treatment for a case of thyroglossal cyst or a case of thyroglossal fistula. Yes, whether they say cyst or fistula, दोनों का treatment same है, and that is nothing else but option C, cyst trunks operation or a cyst trunk surgery. Repeated question. We know in cyst trunks operation we will try to remove the thyroglossal cyst, the thyroglossal tract, and even a part of hyoid bone is removed. That is known as cyst trunks operation. Do remember needle aspiration or incision and drainage is not usually done, because even if you do needle aspiration there will be a recurrence in the patient, and incision and drainage if you do, that will lead to development of thyroglossal fistula. अगर गलती से भी incision और drainage कर दिया तो fistula बन जाएगा, ठीक है? So never do an incision and drainage also. Thyroidectomy, obviously it is not needed. It is not a case of any thyroid malignancy or thyroid cancer that we are going to go for a thyroidectomy. समझे बात? So a very important thing to be remembered. Next, question number 35. Here we are having a 55-year-old male who presents to us with complaints of pain in the calf muscles after walking for a certain distance. We know whenever a patient is going to walk for a certain distance and after that he starts experiencing a cramping pain in the leg, we know it is a classical feature of intermittent claudication. Why I'm calling it as intermittent? Reason is usually whenever you stop or whenever you take rest, the pain is going to disappear. So cramping pain which appears after walking and which usually disappears after rest is known as a intermittent claudication. Okay, so they are asking you now the patient is having a pain which is relieved at rest and it recurs or it reoccurs as soon as he resumes walking. So whenever the patient takes rest, the pain is disappearing, but as soon as he starts walking, again the pain starts beta. Now based on the Boyd's classification or the Boyd's grading, they are asking what is the most likely diagnosis or what is the most likely grade. So we know for intermittent claudication we have the Boyd's classification or the Boyd's grading. According to this Boyd's classification, intermittent claudication has 4 grades. Grade 1 mein, here the patient walks for a certain distance due to which the patient has a cramping pain. Then patient continues to walk with pain. Why? Reason, the pain is not very severe, so the patient continues to walk, and as the patient continues to walk eventually the pain disappears. मतलब patient चलता रहता है और चलने के बाद पेन अपने आप चला जाएगा. Clear? So in grade 1 the patient continues to walk and eventually the pain disappears on walking. Next is grade 2. In grade 2, if they ask you, here the patient walks for some distance, patient gets some pain, and here the pain does not disappear. The patient continues to walk with that pain itself, or the patient continues limping. ठीक है, पेशेंट दर्द के साथ चलता रहता है, पेशेंट कंटिन्यूज टू वॉक विद दैट पेन इटसेल्फ बेटा, द पेन डज नॉट डिसअपियर. Okay, that is grade 2. Grade 3 is pain compels the patient to take rest. In grade 3, once the pain starts, that pain is so severe that the patient has to stop or the patient has to take rest beta. That is what is important to be remembered. Hopefully clear. And lastly, grade 4, if I talk about grade 4 mein, the patient is going to have pain at rest, and that pain at rest starts because of involvement of vasa nervosum. That means now the blood supply to the nerves is decreasing, and that's the reason the nerves are getting damaged, and therefore the patient is having a constant pain or the pain is present even at rest. That is grade 4. Hopefully clear to all of you. Now please tell me, in this condition, if they say that the patient is having pain which is relieved at rest but it reoccurs as soon as the patient resumes walking, so on walking patient has pain, it only disappears at rest, what is the likely grade or the likely stage? I hope all of you are quite aware. So do remember beta, here it is the likely grade 2 case. Okay, answer has to be option B, that is grade 2. Okay, if it was grade 1, what would have been the difference? In grade 1, patient had pain, but the patient would continue to walk with pain and the pain will disappear on walking. Okay, but here definitely they are saying the pain does not disappear on walking, the pain disappears only at rest, or the pain is relieved only at rest basically. So that's the reason it is grade 2. Grade 3 hota, so obviously the pain would be so severe that the pain will not be able to walk at all. That is grade 3. Hopefully clear. So we know this intermittent claudication happens whenever there is blockage of the arteries. Okay, and whenever there is blockage of arteries, the muscles do not receive enough blood supply. That's the reason why patient has intermittent claudication. And when the nerves do not receive enough blood supply, then the patient has rest pain. So do remember, whenever there is a case of gradual arterial obstruction, we know the two main causes for gradual arterial obstruction. One will be atherosclerosis and second is your Berger's disease. In both these conditions, there is a gradual arterial obstruction which decreases the blood supply, especially to the lower limb muscles, and that's the reason patient has these features. First, initially patient has a intermittent claudication. Second, the patient will have rest pain due to nerve damage. Third, the patient will have coldness, numbness, skin ulceration, that is the stage of pre-gangrene. And lastly, the patient has complete necrosis, that is the stage of gangrene beta. Hopefully clear. The Boyd's classification of intermittent claudication have been asked, so do remember that. Like you have to remember NYHA grade for dyspnea in medicine, just like that, remember Boyd's classification for intermittent claudication in surgery. Next, question number 36. Here they are asking you, in a patient who was suddenly started on large amounts of TPN or large amounts of total parenteral nutrition, was at a risk of developing refeeding syndrome. We know, beta, that whenever a person was chronically malnourished, and in that patient, if you suddenly start giving a lot of TPN or a lot of total parenteral nutrition, the patient develops a problem known as refeeding syndrome. Now here they are asking you that which among the following electrolyte imbalances or which among the following electrolyte disturbances is typically not associated with this condition. कौन सा problem associated नहीं होता refeeding syndrome के साथ? That is what they are asking you. I hope all of you are quite aware. See, refeeding syndrome develops when, as I've told you, whenever a person is in a fasting state or whenever a person is suffering from chronic malnutrition. And in such a case, when you give a lot of TPN to that patient, then that patient develops a refeeding syndrome. Now, जब ज़्यादा अचानक से TPN दे दोगे, patient develops refeeding. In this, what happens is, as you have given a lot of glucose and as you have given a lot of nutrition to the patient, basically, do remember what is going to happen. Sorry, as you have given a lot of glucose or a lot of TPN to the patient, basically, we know what will happen. Suddenly there will be excessive release of insulin. Okay, there is an increased insulin secretion, and whenever there is insulin secretion after giving the glucose or after giving the TPN, do remember insulin will send all these electrolytes inside the cell, okay, for the purpose of metabolism or for the purpose of some enzymes. Insulin is going to shift all the phosphate, potassium and magnesium inside the cell. So there will be an intracellular shift of phosphate, potassium and magnesium inside the cell. As phosphate, potassium and magnesium goes inside the cell, amount of all these electrolytes in blood is going to decrease. That means patient will have problems like hypophosphatemia, hypokalemia, hypomagnesemia, or even hypocalcemia is going to develop, right? Even calcium levels are going to decrease, beta. So the patient is actually going to have hypocalcemia. Hopefully clear to all of you. So hypophosphatemia, hypomagnesemia, hypokalemia and hypocalcemia, along with a hypoglycemia also. Reason, as a lot of insulin was released, that's the reason definitely the patient's glucose levels are also going to decrease. The patient will also have hypoglycemia as well, and there will be a sudden deficiency or an acute deficiency of thiamine or vitamin B1. So all these features are seen. So let's say they are asking you which among the following electrolyte disturbances not associated with refeeding. So we know, as potassium goes inside cell, hypokalemia will be seen. Obviously, hyperkalemia is not a feature. Hypocalcemia, yes, it is seen. Hypophosphatemia, yes, it is seen. The answer has to be option B. Hyperkalemia is not seen, beta. Hypokalemia is going to be seen. So yaad rakhna, in refeeding syndrome, everything is going to decrease. Please tell me an important question from pathology and medicine. Which is that condition, beta, where every electrolyte is going to increase except calcium? There will be hyperkalemia, there will be hyperphosphatemia, there will be hypermagnesemia, hyperuricemia also, except there will be hypocalcemia. तो पूरे इलेक्ट्रोलाइट्स बढ़ जाते हैं सिवाय कैल्शियम के. What is that condition from medicine? Let me know in the chat box. Do remember, if there is going to be an acute thiamine deficiency or acute deficiency of vitamin B1, so do remember what will happen. That condition mein, we know thiamine or vitamin B1 is necessary for a lot of enzymes. So obviously there will be blockage of all these enzymes. The pyruvate dehydrogenase in link reaction it will not work. Alpha ketoglutarate dehydrogenase in TCA cycle will not work. Okay, branch chain keto acid dehydrogenase will not work. So multiple enzymes will stop working if there is thiamine or vitamin B1 deficiency, due to which there is going to be energy deprivation in the body, and that causes urinary loss of phosphate, potassium, and magnesium. That will also cause hypophosphatemia, hypokalemia, and hypomagnesemia. Along with that, we know if there is no vitamin B1, what happens? Link reaction does not happen. So all the pyruvate is converted into lactate, and that's the reason why the patient will develop lactic acidosis. Recent question in the FMG exam, that which vitamin deficiency is known to cause lactic acidosis? The answer is thiamine or vitamin B1 deficiency commonly causes lactic acidosis. Hopefully clear to all of you now. So that is important. So how to prevent a case of refeeding syndrome? तो याद रखना, if you want to prevent a case of refeeding syndrome, तो gradually increase the amount of TPN. ठीक है, धीरे धीरे करके बढ़ाना होता है अमाउंट, एक साथ बहुत सारा TPN नहीं देना होता. तो gradually increase the amounts of total parenteral nutrition or the TPN solution given to a patient, especially the ones who are chronically malnourished. Hopefully you have, yes, please remember that is nothing else but tumor lysis syndrome basically. So do remember that. Very good. So tumor lysis syndrome definitely. Okay, so please remember tumor lysis syndrome is not, this is a December 25 exam which was postponed basically to the December, like, sorry, to Jan 2026. But the result will come out as December 25 only. Do remember that. ठीक है, तो प्लीज रिमेंबर, यस, ट्यूमर लाइसिस सिंड्रोम इज द कंडीशन जहां पे एवरीथिंग इज गोइंग टू इंक्रीज बेटा except calcium. That is the case of tumor lysis. Very good. Next important is, if they ask you question number 37, this is the case where you are able to see a 45-year-old female who comes to you with complaints of a greenish nipple discharge. Yes, she is having a greenish nipple discharge, and it is going to be associated with pain in both the breasts. So she is having breast pain or mastalgia. A physical examination reveals there is a bilateral nipple retraction along with little nipple discharge which was there. Histopathology revealed there is dilated ducts in both the breast beta. This is very classical. They have clearly mentioned there is dilatation of lactiferous ducts inside both the breast. They are asking you what is the most likely management of this condition. So we know as soon as they say a greenish nipple discharge along with dilatation of lactiferous ducts, especially in a female around 40 years of age, the diagnosis is very clear. It is a classical case of duct ectasia. Greenish nipple discharge along with dilatation of duct has to be a case of duct ectasia. Do remember, in duct ectasia, as I've told you, commonly happens around 40 years of age. Investigation of choice is nothing else but an ultrasound breast. Investigation of choice is an ultrasound breast which shows you dilated ducts. And if they ask you what should be the treatment, so we know in duct ectasia multiple ducts are involved. So we have to do a conical excision of these lactiferous ducts. And that conical excision of the lactiferous duct is nothing else but called as the option D, Hadfield's operation or the Hadfield's procedure. It was a PYQ. तो याद रखना, whenever we have to do a conical excision of the lactiferous ducts, that is classically known as the Hadfield's procedure, which is considered as the treatment in patients of duct ectasia. Simple mastectomy is not required in this condition. It is not a case of any cancer or a tumor. Microdocectomy. We know microdocectomy is the procedure done in cases of duct papilloma. Duct papilloma is a condition where only a single duct is involved. And whenever only a single duct is involved, beta, we have to go for a procedure called as microdocectomy. Clear? Lobectomy is again done for lumps or cancers usually. याद रखना about nipple discharges. We know that if they say there is a blood stain nipple discharge, so do remember, blood stain nipple discharge from a single duct is more commonly due to duct papilloma. Yes, the most common cause for a blood stain nipple discharge from a single lactiferous duct is duct papilloma. For duct papilloma, you can do a ductoscopy or a ductography, and the treatment I've already told you. For a duct papilloma, we go for a procedure known as microdocectomy beta. We go for a procedure known as microdocectomy. That is also PYQ. Be aware of that. Secondly, if there is a blood stain nipple discharge from multiple ducts, then the cause is breast cancer. Blood stain nipple discharge from multiple ducts, then the leading cause or the commonest cause is breast cancer. Whereas if they say a serous nipple discharge from the breast, the most common cause for serous nipple discharge from the breast, answer is a fibrocystic disease, also known as fibroadenosis. The fibrocystic disease or fibroadenosis is the commonest cause for a serous nipple discharge from the breast, and it is a cause for cyclical mastalgia. We know cyclical mastalgia or cyclical pain in breast happens due to fibrocystic disease. Clear? Chala. Next is question number 38. You are able to see we are having a 28-year-old primi gravida, that means a female pregnant for the very first time, who has delivered a baby via a normal vaginal delivery 5 days ago. So she has just delivered a baby 5 days ago. So she might be lactating the baby right now. Now she has come to your clinic with complaints of pain during breastfeeding associated with fever, chills for the past 2 days. So since the last 2 days, basically, beta, she is having pain while she is breastfeeding the child, and there are also fever and chills. On physical examination, there is breast engorgement which is seen along with tenderness. Engorgement means fullness. So there is a fullness or engorgement of the breast. Along with that, there is a tenderness inside the breast, and there is a fluctuation which is noted. We know fluctuation sign is positive whenever there is collection of some fluid. Okay, that is the reason the fluctuation is positive. Definitive treatment option is, please let me know what is going to be the diagnosis of this case. The female is lactating right now, and during lactation she is having pain, engorgement, tenderness, fluctuation, and fever and chills. So what is the provisional diagnosis of this case? I hope all of you are quite aware. The provisional diagnosis of this case, I hope all of you are quite aware. It is a classical case of nothing else but breast abscess, beta, right? So we know as soon as they said there is fever, there is chills, there is tenderness, there is fluctuation. We know fluctuation is a late sign but a very classical sign of breast abscess. That means whenever there is collection of fluid inside, collection of pus inside the breast. We know the commonest cause for a breast abscess is Staph aureus or a Staphylococcus aureus, right? The commonest cause for a breast abscess case is a Staph aureus or Staphylococcus aureus, and that enters from the baby's mouth. The source for that Staph aureus is baby's mouth. And yaad rakhna, the risk factor responsible for causing breast abscess is a cracked nipple. This was a PYQ NEET once. So the most important risk factor causing a case of breast abscess is the cracked nipple. We know if the patient is having breast abscess, you can see all these signs of inflammation, like there will be redness, warmth, swelling in the patient. Along with that, there will be fever. And investigation of choice to confirm a diagnosis of breast abscess is ultrasound, and on that ultrasound you can see some fluid collection that confirms your diagnosis of breast abscess. Now here they have basically asked you what is the definitive treatment, and we know the definitive treatment, most appropriate treatment or the best treatment for a case of breast abscess is nothing else but option C, that is you have to perform an incision and drainage, and obviously along with incision and drainage you have to give antibiotics. Okay, but do remember the antibiotics that we usually give in patients of breast abscess, they are usually safe antibiotics like cloxacillin or dicloxacillin. You have to give antibiotics like cloxacillin or dicloxacillin. Understood? So do remember that incision and drainage done with the number 11 blade as we discussed yesterday, and along with that antibiotics like cloxacillin or dicloxacillin. Option A says stop breastfeeding and antibiotics. Usually we don't need to stop breastfeeding, beta. Okay, usually you can continue breastfeeding from the opposite breast also. Okay, so we don't need to stop breastfeeding as such unless and until it is a very severe case. And secondly, antibiotics, yes, antibiotics are given, but it is not the definitive treatment. Option B, antipyretics and antibiotics, yes, both antipyretics and antibiotics will be prescribed to the patient, but it is not the definitive treatment. It is an adjuvant treatment. Okay, whereas options D says needle aspiration. Do remember that needle aspiration or ultrasound guided aspiration, it is definitely done in breast abscess, but it is not the definitive, it is the first line treatment for a case of breast abscess. So if they would have asked you that what is the first line treatment in a case of breast abscess or the next line of treatment, so we know first line or next line agar पूछते तो my answer would have been option D, that is ultrasound guided needle aspiration. We should go for 2 attempts of an ultrasound guided needle aspiration. If those attempts fail, then we go for an incision and drainage. But here they directly ask you about the definitive or the most appropriate management to go for IND or incision and drainage as the answer. Hopefully clear. Whereas if they talk about a case of breast engorgement, which is another favorite of your examiners, do remember breast engorgement is nothing else but fullness in the breast. So whenever there is breast engorgement, they will say the child is refusing the feed, the child is not taking the feed. Second, there is pain and fullness inside the breast. Yes, they will only complain of pain and fullness. They will not talk anything about tenderness. They will not talk anything about fluctuation as such. They will not talk anything about fever and chills especially. Okay, fever and chills too will never be seen. So obviously then it would be a case of engorgement if no other features are there. And treatment for a case of breast engorgement is expression of milk. You have to express out the milk beta with warm moist compresses around the breast. So whenever you are expressing out the milk manually or with a pump, please remember use some warm moist compress so that the expression of milk is easier. Clear? Chalo. Next is question number 39. Here there is a 50-year-old female who is a teacher by occupation presented with complaints of swelling in front of the neck. So obviously there is a midline neck swelling which is seen. Okay? Whereas they are saying this swelling moves with deglutition. We know all the swellings related to thyroid, they usually move with deglutition. Okay? All of them do not move with protrusion of tongue. With protrusion of tongue, only the thyroglossal cyst moves. But with deglutition or with swallowing, any swelling related to thyroid will move beta. Though it is a thyroid swelling because it is moving with swallowing or deglutition. Examination reveals there is a multinodular goiter. So as I've told you, it is a thyroid swelling. So there is a case of multinodular goiter with high TSH values beta. Now they are saying after achieving euthyroid state. Euthyroid means once basically the thyroid hormones will normalize. So after achieving a euthyroid state, the patient was taken up for a total thyroidectomy. They are asking you that which is going to be the most common nerve injured during this procedure of total thyroidectomy. That is their question. But before that, please tell me what is the provisional diagnosis? An elderly 50-year-old female coming to you with a thyroid swelling which was due to multinodular goiter. Now they have planned a total thyroidectomy basically beta. Why? Because there would be a risk of which cancer usually in this condition. They would have planned basically the total thyroidectomy because the female is at a very high risk of which cancer basically over here. Let me know in the chat box. Anybody, let me know in the chat box. Which cancer risk is going to be high? I hope all of you are quite aware. It is more likely going to be a case of a follicular thyroid cancer beta. Yesterday I've told you about papillary. We know that papillary thyroid cancer is the most common thyroid cancer, but it basically happens in young patients around 20 to 40 years of age. Secondly, it happens due to risk factors like radiation exposure, thyroglossal cyst, or Hashimoto's thyroiditis. Whereas follicular thyroid cancer happens in elderly patients more than 50 years of age. Secondly, the most important risk factor for a follicular thyroid carcinoma is a multinodular goiter or iodine deficiency. So as the patient may have a risk of follicular cancer basically, that's the reason we have planned a total thyroidectomy in her. Now, if you are planning a total thyroidectomy basically beta, that we know in this condition definitely do remember why we plan a total thyroidectomy directly. Reason is even if you do a FNSC beta in cases of follicular thyroid cancer, we know it is not diagnostic. Yesterday itself I've told you papillary thyroid cancer mein FNSC will be diagnostic, but in follicular thyroid cancer FNSC is not diagnostic, which is a repeated question. Why? Because in follicular thyroid cancer FNSC or a fine needle aspiration cytology cannot differentiate whether it is a case of a follicular carcinoma or a follicular adenoma. So it cannot differentiate a malignant and a benign tumor. That's the reason. Therefore, here the investigation of choice is a biopsy. And which kind of biopsy? An excisional biopsy. That is, remove the thyroid gland, send it for biopsy after that. That's the reason we have planned a total thyroidectomy. Understood? Here, if they ask you what is the most common nerve injured, so I have told you time and again that the most common nerve injured during a total thyroidectomy surgery nowadays is option A, that is a ELN or the external laryngeal nerve. Right now, it is not RLN anymore. The commonest nerve injured is ELN or external laryngeal nerve, and whenever external laryngeal nerve injury happens, we know the cricothyroid muscle is paralyzed, which is a tensor muscle. Okay, the cricothyroid muscle is paralyzed, which is tensor muscle, and that's the reason patient would complain of poor quality of voice beta. So external laryngeal nerve injury will cause a cricothyroid muscle palsy leading to a poor quality of voice. So if they say after total thyroidectomy, patient has poor quality of voice, think about ELN or external laryngeal nerve injury. Whereas RLN may be injured, and whenever RLN or the recurrent laryngeal nerve is injured, what are the features? Do remember, whenever there is a RLN palsy or a recurrent laryngeal nerve palsy, if it is a unilateral RLN injury, patient would have complaints like hoarseness of voice. Whenever it is a unilateral RLN palsy, there is hoarseness of voice. Whereas whenever there is bilateral RLN palsy, we know bilateral RLN palsy mein vocal cords will be closed. Okay, vocal cords will be in a median position. That's the reason patient will have problems like stridor and respiratory distress. In a bilateral RLN palsy, patient will have problems like stridor and respiratory distress. Hopefully clear to all of you now. Chalo. We know these nerves are not commonly injured in thyroidectomy surgery. It is mainly the ELN followed by RLN. Understood? Next, if I talk about question number 40, it states after a laparoscopic cholecystectomy, after doing a laparoscopic cholecystectomy, patient started developing pain and fever after few days of discharge. Now, on evaluation, a 3 by 6 centimeters of fluid collection was present under the liver. So, in the subhepatic space or in the peritoneal cavity, you are able to see some fluid collection after the lap chole surgery. Beta. Okay? Now, they are asking you what should be done next in this condition. So, I hope all of you are quite aware. Whenever after a cholecystectomy surgery, they say there is collection of fluid. Okay, we have to think about nothing else but a case of bile leak, and that bile leak or that bile collection will be called as a bilioma. Okay, so you have to think about a bile duct injury due to which there will be a bile leakage after the surgery, and that will lead to a collection of bile called as bilioma. Whenever there is a bilioma in a patient, the first step to be done is an ultrasound abdo. Whenever there is a bile collection or a bilioma, first step to be done is an ultrasound abdomen. Followed by that, please remember, you have to go for a ultrasound guided pigtail catheter insertion and drainage. Followed by which you have to insert the pigtail catheter and drain all the bile or drain all that bilioma which has been collected. Basically, clear? After that is done, then you have to evaluate, or then you have to investigate for the bile duct injury. You will see where is the bile duct injury, how big is that bile duct injury, everything, and that is done with the investigation of choice called as MRCP. We know MRCP or magnetic resonance cholangiopancreatography is the investigation of choice for bile duct injury or the bile leak. Whereas if that doesn't help, then you go for the gold standard investigation, and we know gold standard investigation for bile duct injury or bile leak is ERCP, that is endoscopic retrograde cholangiopancreatography. After evaluating the bile duct injury, then if the patient had come to you within 2 days of surgery, then you should go for a immediate re-exploration and repair. If the patient has come to you within 2 days, then go for a immediate re-exploration and repair in the OT. But if the patient has presented to you after 2 days, then the infection or contamination would be more. If the patient has presented to you after 2 days, then go for a procedure that is ERCP with stenting. After 2 days of surgery, then only go for ERCP with stenting. This is a repeated question of FMGE exam. Clear? Now here definitely they have asked you that what we should do next in this. So they are saying basically on evaluation a 3 by 6 centimeter of fluid collection was found. That means they might have done an ultrasound on which they were able to see a fluid collection. Obviously after this, the next step is nothing else but a pigtail catheter insertion and a drainage. The answer has to be option A, that is ultrasound guided pigtail catheter drainage has to be done. Okay, re-exploration of the wound and T-tube insertion, that will be decided once basically beta we have done evaluation with MRCP or ERCP, not before that. ERCP was stenting, that is also going to be decided after you have done a ERCP or MRCP. Okay, perform MRCP and give antibiotics? No. Before that, drain the bile collection or drain the fluid. That is a repeated question. Either they ask you the treatment or they ask you what is the next step. So be aware of that. This is what is the protocol that we follow for a bile leak or a bile duct injury after a cholecystectomy surgery. Clear? Next, here there is a question number 41, which asks you that we are having a 32-year-old male who presented to us with complaints of difficulty in swallowing, that is dysphagia, along with regurgitation, and there is weight loss. Obviously, due to dysphagia, the patient is having weight loss. Barium swallow image has been given below. They are asking you what is the appropriate investigation to confirm the diagnosis. I hope all of you are quite aware about this Sarkari question now. Okay, this Sarkari question has been rectified to each and every one. So you can see beta, whenever a patient comes to us with complaints of difficulty in swallowing or dysphagia, the first investigation to be done is a barium swallow. And when we have done a barium swallow, you are able to see a smooth tapering or a smooth narrowing. And we know the smooth tapering or smooth narrowing is classically referred to as the bird beak appearance. The smooth tapering or smooth narrowing, we call it as the bird beak appearance. And please tell me, what is the provisional diagnosis? Whenever the barium swallow shows us the bird beak appearance, what is the likely diagnosis? So either we are able to see a bird beak appearance, or I can call it as the pencil tip sign. So we can call it as the bird beak appearance or the pencil tip sign. Do remember, if there is bird beak appearance, if there is pencil tip sign, or if there is smooth tapering, I will prefer calling this appearance as bird beak, pencil tip, or smooth tapering. If any of these three options are not there, then we can call it as rat tail also. Okay? Preferred options will be bird beak, pencil tip, or smooth tapering. If nothing is there, then you may mark it as rat tail appearance. Hopefully clear. We know whenever there is a barium swallow showing you a classical case of bird beak appearance, it is a case of achalasia cardia. Okay, it is due to achalasia cardia, which happens due to loss of ganglionic cells from the Auerbach's plexus or the Myenteric plexus, right? So whenever there is loss of ganglionic cells from the Auerbach's or the Myenteric plexus, that causes achalasia cardia in a patient. One point to be remembered. And second, it can also happen due to deficiency of neurotransmitters like nitric oxide and VIP. That has been a question. So which neurotransmitter deficiency causes achalasia? To do remember, deficiency of neurotransmitters like nitric oxide and VIP is also an important cause for achalasia cardia. Okay? And we know achalasia cardia mein the lower esophageal sphincter is contracted or the lower esophageal sphincter fails to relax. That's the reason why patient has dysphagia and the bird beak appearance on barium swallow. Whereas as the lower esophageal sphincter is contracted, the pressure at lower esophageal sphincter is very high. And to measure that pressure, I hope all of you are quite aware, all of you might have answered, the investigation of choice to confirm a case of achalasia cardia. Answer is nothing else but option B, that is a manometry. Bhai, isme gadbad nahi karo. Please remember, do not make a mistake in this question. Investigation of choice for a case of achalasia cardia is nothing else but option B, that is a esophageal manometry, on which you will find in achalasia cardia cases, the lower esophageal sphincter pressure will range between 26 to 100 millimeters of mercury. The pressure is between 26 to 100 millimeters of mercury. And yaad rakhna, the treatment for a case of achalasia cardia is the classical Heller's myotomy. So the best treatment is Heller's myotomy. There are multiple other options, but the best treatment for a case of an achalasia cardia, answer is a Heller's myotomy. That has to be kept in mind. No issues still here. Whereas if they show you that a patient comes to you with dysphagia again, but this time whenever the patient came to with dysphagia and we did a barium swallow, we were able to see the classical corkscrew or the rosary bead appearance. Whenever we know a case of dysphagia shows you a corkscrew or a rosary bead appearance on the barium swallow, it is a classical case of diffuse esophageal spasm or a distal esophageal spasm, right? It is a classical case of DES, diffuse or distal esophageal spasm. In this condition also, the investigation of choice is manometry. And when you do a manometry, you will find the pressure in diffuse esophageal spasm is going to exceed more than 120 millimeters of mercury. The pressure in patients of DES or diffuse esophageal spasm is going to be more than 120 millimeters of mercury. And the treatment here also is a myotomy surgery. Here also the treatment is myotomy surgery. Whereas if I talk about another condition, here you are able to see that the barium swallow is showing you two features. First one is definitely a irregular filling defect. Can you see? This is a irregular filling defect which is seen. Please tell me, irregular filling defect, we all know it is a feature of esophageal carcinoma. Let me know, regular filling defect or a smooth filling defect is a feature of. Irregular filling defect on barium swallow is seen in esophageal carcinoma, but a regular or a smooth filling defect on the barium swallow is a feature of which condition? Let me know in the chat box. We know esophageal carcinoma is more commonly a squamous cell carcinoma beta, followed by an adenocarcinoma. More commonly it is a squamous cell carcinoma, and the commonest site is the upper 2/3 or the middle 1/3. The most common site is going to be the middle 1/3 or the upper 2/3. तो याद रखना, squamous cell carcinoma of esophagus is commonly seen in the middle 1/3 or the upper 2/3. But if they ask you adenocarcinoma of esophagus, do remember adenocarcinoma of esophagus, which happens after Barrett's, is commonly seen in the lower 1/3 of esophagus. ठीक है? Esophageal carcinoma में, as there will be dysphagia beta, we will do a barium swallow on which you are able to see the classical irregular filling defect. Along with that, a irregular narrowing pattern called as rat tail appearance, right? The irregular narrowing appearance called as the rat tail appearance, which is going to be seen. Hopefully clear. So do remember these points for a case of an esophageal carcinoma. And obviously the investigation of choice for an esophageal carcinoma is a upper GI endoscopy and a biopsy. So endoscopic biopsy is the investigation of choice for a case of esophageal carcinoma, not for a achalasia cardia case. Clear hai baat? That is important. And we know in achalasia cardia and in esophageal carcinoma, in both the conditions, patient has dysphagia. How to differentiate? We know in patients of esophageal cancer, basically, whenever there is a dysphagia over here, beta, this dysphagia is actually going to be more severe for solids as compared to liquids. In esophageal cancer, there is more severe dysphagia for solids as compared to liquids, whereas in achalasia cardia, it is completely opposite. In achalasia cardia, there is more dysphagia for liquids as compared to solids. Achalasia mein, there is more dysphagia for liquids as compared to solids. Hopefully clear? Chalo. No issues with this, anybody? Done with this? So do remember, if I talk about a smooth or a regular filling defect on barium swallow, it is a classical case of a benign esophageal tumor called as esophageal leiomyoma. So a benign esophageal tumor called as esophageal leiomyoma has a smooth or a regular filling defect. That was the question I was asking you. Clear? Next important, if I talk about, is question number 42. Here we are having a 30-year-old person. This 30-year-old person attended the office party. Okay, he has attended the office party on the New Year's Eve on and he had a binge drinking episode. Okay, he had a binge drinking episode followed by which there were multiple episodes of vomiting. So he had a binge drinking followed by multiple episodes of vomiting, and there were few vomiting episodes with presence of blood. And we know whenever a patient is going to vomit out blood, we call it as hematemesis, and hematemesis is a feature of upper GI bleeding or upper gastrointestinal bleeding. They are asking you what is the most probable diagnosis. So I hope all of you are quite aware. A young patient who has undergone a binge drinking and multiple episodes of vomiting, if that patient is basically having hematemesis after that, it is a very classical presentation of option C, that is Mallory-Weiss. Yesterday I've told you about esophageal perforation or Boerhaave syndrome also. Okay, so what is the difference? I have uploaded a reel also or a short also on the same thing to differentiate that confusion. Now please remember, if there is a binge eating or a binge drinking episode beta, after which patient is having retching or vomiting, followed by which, if the patient is having features of macular striae like patient is having chest pain, vomiting and subcutaneous emphysema, along with signs of pneumomediastinum. Signs of pneumomediastinum, that is the Hammond-Crunch sign or the continuous diaphragm sign. Hammond-Crunch sign on auscultation and continuous diaphragm sign on chest x-ray. Then we know the diagnosis is a case of Boerhaave syndrome, which is a spontaneous esophageal perforation. But if definitely beta, they say after this binge drinking or binge eating episode followed by retching or vomiting, patient is only having upper GI bleeding, that is patient is having features of hematemesis or melena, then the diagnosis is Mallory-Weiss beta. That is what is important. So here, as they have said, after vomiting patient is only having hematemesis, so the diagnosis becomes Mallory-Weiss tear. We know Mallory-Weiss tear happens due to a partial tear in the lower esophagus. And do remember, the most common vessel to bleed in patients of Mallory-Weiss tear, if they ask you, answer is the left gastric artery. The commonest vessel to bleed in patients of Mallory-Weiss tear, answer is the left gastric artery. One point is that. And in patients of Mallory-Weiss tear, if they ask you that what is going to be the treatment, so I hope all of you are quite aware. Mallory-Weiss tear is a self-limiting condition, right? Mallory-Weiss tear is a self-limiting condition. So majority cases will spontaneously resolve. अपने आप bleeding रुक जाएगी. So you can give IV fluids and basic resuscitation, but there is no definitive treatment needed because majority cases are self-limiting for Mallory-Weiss. For Boerhaave syndrome, obviously we had to do a thoracotomy along with a repair, but that is not needed for Mallory-Weiss as such. Clear? Bleeding esophageal varices, we will discuss it. It will have a history of chronic liver disease, that is cirrhosis, or portal hypertension. It will not give you any history of binge drinking or vomiting or retching episodes. Clear? So if there is a history of cirrhosis or portal hypertension, then we will talk about a case of bleeding varices. Peptic ulcers, peptic ulcers could be a case definitely over here, because after binge drinking the patient may have exacerbation of peptic ulcers, and that would lead to a sudden vomiting and sometimes even hematemesis. But again, do remember, there was no previous history which was given, right? There was no previous history which was given basically earlier. They would have said about the previous history of abdominal pain or ulcers or something like that, then we would have said yes, it is an exacerbation of a peptic ulcer. But here it does not seem to be a case of that. Clear? They have neither mentioned patient is a chronic alcoholic, chronic smoker, ऐसा कुछ mention नहीं है. So again, peptic ulcer becomes less likely as the case. Hopefully clear. Do remember, we know peptic ulcer is actually the most common cause for a upper GI bleeding. So whenever they say upper GI bleeding, that is hematemesis or melena, the most common cause is going to be peptic ulcers itself. That has to be kept in mind. One thing is that, and peptic ulcer disease mein, the most common vessel to bleed is the gastroduodenal artery, right? The most common vessel to bleed in patients of peptic ulcer disease is the gastroduodenal artery. That has been a PYQ in the examination. So gastroduodenal artery is the commonest vessel to bleed in peptic ulcer disease. Hopefully clear. Chalo. So these are the points that have to be remembered. Okay, no issue still here. Hopefully this doubt was resolved properly. ठीक है, चलो okay. Next important question number 43, it states, we are having an elderly smoker patient who presents to you with a history of intermittent claudication. So an elderly smoker presenting with intermittent claudication, and there is now a recent onset numbness along with color changes in the left leg. So we know whenever there is history of intermittent claudication along with numbness and color changes now, that means it is a case of a gradual arterial obstruction like atherosclerosis or Buerger's disease. And that's the reason, as the vessel have been obstructed or blocked, the leg is not receiving enough blood supply, due to which the patient is having all these symptoms, right? Now they are saying ABPI was calculated. What is ABPI? It is ankle brachial pressure index. So ABPI is ankle brachial pressure index, which is a ratio of systolic BP at the ankle upon systolic BP at the arm. ठीक है, तो systolic BP of lower limb upon systolic BP of upper limb, that is the ratio known as ABPI. The normal ABPI value, we know slightly there is a higher blood pressure in the lower limbs beta. That's the reason the normal ABPI value will be 0.9 to 1.4, right? The normal ABPI value can range between 0.9 to 1.4. But whenever the ABPI will decrease, whenever the ABPI is less than 0.9, it is suggestive of intermittent claudication. Yes, that means if a patient is suffering from intermittent claudication, you will find the ABPI value is less than 0.9. If the patient is suffering from rest pain, when the patient progresses to the second stage, that is rest pain, then the ABPI decreases further, it goes to less than 0.5. But here they are asking you beta, that at what ABPI the patient will be at a risk of imminent gangrene. Recent question. So if they say the patient will be at a risk of imminent gangrene, or the patient will be at a risk of critical limb ischemia, at which ABPI value? I hope all of you are quite aware. Yes, if there is calcification of the blood vessel, the ABPI will be more than 1.4. Yes. So yaad rakhna one point, that patient will be at a risk of imminent gangrene, or patient will be at the risk of critical limb ischemia whenever the ABPI value is 0.3 or less than 0.3 beta. So less than equal to 0.3, you can say it is the ABPI value at which there is a risk of imminent gangrene or critical limb ischemia. Hopefully clear. At 0.1, there will be a complete gangrene. There will be not a risk of gangrene, but rather there will be complete gangrene. So whenever the ABPI value touches 0.1 beta, that means already gangrene has started or necrosis has started in the leg then. Clear? So at 0.1 ABPI, the patient would have gangrene already. Hopefully clear? Chalo. So these are the points that you have to remember. Next important, if I talk about now, is question number 44. Here they state that a patient has been brought to the ED of the emergency department following a severe maxillofacial trauma beta. ठीक है. So they are saying the patient is having a severe maxillofacial trauma, okay, which was sustained in a road traffic accident. So he met with a road traffic accident that led to this maxillofacial trauma. They are saying that the airway of the patient has been compromised, okay, and immediate intervention is required in this case. They're asking you what is the most appropriate immediate management for this patient. Recent question in FMG exam, they're asking you what is the most appropriate immediate management, okay, and or an emergency management in this condition. Okay, so now whenever the patient has suffered from a trauma beta, we know we have to follow the ATLS protocol or the guidelines of ATLS protocol to manage this patient. ATLS is nothing else but advanced trauma life support, and in advanced trauma life support, the first step is to do a basic resuscitation and to save our patient's life. To do a basic resuscitation and to save the patient's life, when we do basic resuscitation, the sequence of resuscitation that we follow in ATLS protocol is A, B, C, D, E. We know in the BLS or ACLS protocol of cardiac arrest, you follow C, A, B, but in the ATLS protocol of trauma, you follow the sequence A, B, C, D, E, where utmost priority is given to airway. So A stands for airway management. Okay, B stands for breathing management, C stands for circulation management, D stands for disability. And this was a PYQ that D in the basic resuscitation of ATLS protocol stands for. So answer is disability. And E stands for exposure with environment control. E for exposure with environment control. Do remember, whenever the patient's airway is compromised, the first step that we do is always clear the airway beta. If there is any obstruction, you have to clear that first. Second, do suctioning of the airway. There are some secretions in the airway which causes a blockage due to aspiration, so you have to suction the airway. Even after that, if it doesn't open up, then perform some maneuvers. One is the head tilt and the chin lift maneuver. You can perform the head tilt and the chin lift maneuver, or second one is the jaw thrust maneuver. Second is the jaw thrust maneuver. If that also doesn't help, even after this, if the airway is still compromised, then you have to go for an AT intubation or an endotracheal intubation beta. In those conditions, you should go for an AT intubation or an endotracheal intubation. If they say that endotracheal intubation is difficult or endotracheal intubation fails, okay, whenever endotracheal intubation is difficult or endotracheal intubation fails, in those conditions, either we can go for a procedure known as cricothyroidotomy, that is a needle cricothyroidotomy, where we insert a needle in the cricothyroid membrane, or a tracheostomy. Do remember, if the patient's condition is rapidly worsening, बहुत जल्दी patient की condition खराब हो रही है, तो go for an emergency or an immediate management called as cricothyroidotomy. But cricothyroidotomy cannot be a definitive airway. Reason, cricothyroidotomy can work as an airway for only 1 hour. After that, you have to go for a tracheostomy. So the definitive airway will always be a tracheostomy. So whenever intubation fails, if the patient is stable, directly go for tracheostomy. But if the patient is not stable, first go for a cricothyroidotomy, followed by that go for a tracheostomy. Okay, hopefully all of you are quite aware. Now let me know in the chat box that in this condition, what is going to be the most appropriate immediate management or next step to manage this case. Let me know in the chat box. So this is the procedure of cricothyroidotomy that we are doing. Right, as you can see, we are basically creating opening in the cricothyroid membrane beta. Okay, that is what is done in cricothyroidotomy. I hope all of you are quite aware about tracheostomy, that the best site that we use for a tracheostomy is between the second and the third tracheal ring. Mid tracheostomy is commonly done. So between the second and the third tracheal ring is the best site to be used for a tracheostomy. And tracheostomy is generally done in the rose position. Tracheostomy is commonly done in rose position. Whereas endotracheal intubation is done in the barking dog position or the morning sniffing position. We do endotracheal intubation in barking dog or the morning sniffing position, right? Now, please tell me what is the answer for this question. Very good. Yes. So here, please remember, why not intubation then? Why not orotracheal intubation? Reason is beta, as the patient is having a severe maxillofacial trauma. If the patient is having a severe maxillofacial trauma, intubation is quite difficult, or intubation is usually going to fail. So even if you try intubation beta, the orotracheal or the endotracheal intubation will not be possible. And as it is not possible, that's the reason we have to go for either a tracheostomy or cricothyroidotomy. But here, As they have asked you the immediate management, we know the immediate management that we will prefer is option C, that is a cricothyroidotomy to be done, and later on we can go for a tracheostomy in this patient. Clear about bag and mask ventilation is not going to help if the airway has been compromised. If the airway is intact, then you can go for bag and mask. If the airway is compromised, then bag and mask ventilation does not help. Hopefully clear. Chalo. Next important is, here they are saying that question number 45 is there. They say a 50-year-old male patient has presented to you with a fluctuant mass inside the oral cavity floor as depicted in the image below. So in the floor of the oral cavity, you are able to see a fluctuant mass containing fluid, obviously. Okay, the a thorough history and examination reveals it is a case of recurrence. That means patient had a similar swelling or a similar mass earlier also. They are asking you what is the best approach for managing his condition. So we know whenever there is a fluctuant mass in the floor of the oral cavity like this, it is nothing else but a case of a ranula beta. So ranula is nothing else but a mucus extravasation cyst in the floor of mouth. So whenever there is a excess mucus containing cyst in the floor of mouth, we know it is called as ranula, and this ranula is going to be positive on a trans-elimination test. Rather, I would say that ranula is brilliantly positive on a trans-elimination test. It glows on the trans-elimination basically. Clear? They are saying that it is a case of recurrence. So please tell me what is going to be the best treatment or the best management. We have discussed in classes already that what is the best treatment for a case of ranula. Option A says incision and drainage. Option B says needle aspiration. Option C says excision. And option D says marsupialization. What is going to be the best answer for this case? Yes, the answer for this case is nothing else but option C, that is a surgical excision. Okay, to do two reasons for it. One, the best treatment for a case of ranula is always excision, does not matter whatsoever. Reason is, if you do excision beta, there is no risk of recurrence at all. Okay, so once you do excision, you are going to excise the sac or the cyst. Along with that, you are also going to excise the sublingual gland, and once we remove the sac as well as the sublingual gland, there will be no recurrence at all. So surgical excision is the overall best treatment. One thing is that, okay, they have asked you the best approach. Second important is they have also given a history of recurrence. So please remember, if there is a recurrence, again, doing a marsupialization is not going to be effective, because after marsupialization, again, there can be a chance of recurrence. So it's always better to go for a surgical excision. Hopefully understood. Incision and drainage are done for abscesses, not for a ranula. Needle aspiration will cause recurrence again. So if they ask you, when we do a surgical excision of ranula, which is the most common structure injured? The most common structure injured during a ranula surgery in floor of mouth. Answer is submandibular duct or the Wharton's duct. So submandibular or the Wharton's duct is the commonest structure that is injured during a ranula surgery. Whereas a repeated PYQ in the FMGE exam, that which is the most common nerve injured during a ranula surgery. So whenever you do a ranula surgery or a surgery in floor of mouth, the commonest nerve that is injured is lingual nerve. And we know whenever this lingual nerve is injured, patient will have loss of general sensations from anterior two-third of tongue. Patient will have loss of general sensations from anterior two-third of tongue. Do remember, this is a very common question asked in the FMG examination, twice or thrice read. Okay, so do remember. Next is question number 46. We are having a case where they say a patient comes to the OPD with complaints of hoarseness of voice recently, and the patient also gives history of some retrosternal burning sensation in the chest. Along with that, there is a sour brush along with epigastric pain. Which among the following is the next best step for the diagnosis of the patient? I hope all of you are quite aware about the provisional diagnosis of the case. We know a classical triad, that is epigastric pain, retrosternal pain, and a retrosternal burn. Okay, epigastric pain, retrosternal pain, and a retrosternal burn. It is a very classical triad seen in patients who are usually suffering from GERD beta, that is gastroesophageal reflux disease. So we know it is a classical case of GERD. In patients of GERD, there will be sour brush, there is going to be hoarseness of voice. These are the features which can be seen. And we know GERD happens due to the frequent lower esophageal sphincter relaxation. अगर बार बार तुम्हारा एलियस रिलैक्स हो रहा है, So due to the frequent ileus relaxation, patient develops GERD, due to which the acid of the stomach goes back into the esophagus beta. And whenever a patient is having GERD, please tell me what should be the next best step for diagnosis of the case. Option A says esophageal manometry, option B says flexible endoscopy, option C says barium swallow, or option D says 24-hour pH monitoring. So if they ask you about GERD, what is your next best step basically? And the answer to this question is the investigation of choice to be done first. And this is the basic problem I have seen in people, that investigation of choice for GERD, please remember, is not a 24-hour pH monitoring. Investigation of choice in patients of GERD is an upper GI endoscopy, we know. So upper GI endoscopy is the investigation of choice for GERD, whereas 24-hour pH monitoring is the gold standard investigation. 24-hour pH monitoring is the gold standard investigation. I have told you multiple times in class one thing, that whenever a patient comes to you with symptoms of GERD, the first investigation that you do an investigation of choice initially, na bhai, or you directly go for gold standards. So initially we always go for investigation of choice. Reason, in 90% cases, the investigation of choice will give us the diagnosis. Okay, only in 10% cases it may not confirm the diagnosis. So in patients of GERD, always remember the investigation of choice is option B, that is flexible endoscopy or an upper GI endoscopy to be done. This is the next best step. And if the flexible endoscopy or upper GI endoscopy fails to prove the diagnosis, in those conditions only we should go for a 24-hour pH monitoring, because it is more invasive. Clear? And whenever we do 24-hour pH monitoring, patient's pH of the esophagus will be less than 4. If the patient's esophageal pH is less than 4 for minimum 4 times in a duration of 24 hours, then we say it is a diagnosis of GERD. अगर पेशेंट का पीएच 4 से कम होता है, कम से कम 4 बार 24 घंटे में, तो उसको GERD बोलेंगे. और the patient's DMISTR score is more than 14.7, that is GERD. We know in patients of GERD, treatment is lifestyle modifications to be done. That is, advise the patient to quit smoking and alcohol beta, and advise the patient to avoid any kind of fried, fatty, spicy food, avoid tea, coffee, alcohol, all of that. Okay? Along with lifestyle modifications, you will advise the patient PPIs, that is proton pump inhibitors, the drugs like lansoprazole, pantoprazole, all of the prazoles basically. Along with that, you can even give prokinetics like mozapride or etopride. Do remember, esophageal manometry is the investigation of choice for motility disorders. Problems like achalasia cardia, diffuse esophageal spasm, nutcracker esophagus. In those conditions, manometry is used to measure the pressure. Whereas barium swallow is the first line investigation to be done in dysphagia. Whenever a patient has dysphagia, then the first investigation to be done is barium swallow. Here they did not even say dysphagia. So why to do a barium swallow, right? So that is important. We know if the patient is having a long-standing GERD beta, then there can be a complication which develops. And we know that complication is classically called as Barrett's. So when the GERD is not treated for a very long duration of time, the patient develops a complication known as Barrett's esophagus. We know Barrett's esophagus may, if you do an upper GI endoscopy, you will find this red velvety mucosa. And this red velvety mucosa is basically an abnormal mucosa where the squamous epithelium has changed into columnar. Okay? In Barrett's esophagus, the squamous epithelium of esophagus changes into columnar, that is known as intestinal metaplasia. And if they ask you what is the hallmark feature of Barrett's esophagus, I hope all of you are quite aware. The hallmark feature of Barrett's esophagus are known as the goblet cells beta. The goblet cells is considered as the hallmark feature of Barrett's esophagus, and the stain used for goblet cells, we all know it is Alcian blue. The stain that we use for goblet cells is known as Alcian blue stain. Clear about? So this is a common question repeated and common mistake done by everyone. So hopefully now, yes, they have asked next best step, bhai. They have asked next best step. Next best or best step में there is a difference, right, in English? नेक्स्ट बेस्ट का मतलब और बेस्ट का मतलब दोनों में डिफरेंस होता है या नहीं? इज देयर अ डिफरेंस बिटवीन बोथ नेक्स्ट बेस्ट एंड बेस्ट? होपफुली नाउ इट इज फाइन, अंडरस्टूड, क्लियर? नेक्स्ट बेस्ट और बेस्ट में जमीन आसमान का फर्क होता है, डू रिमेंबर दैट. No issues with this. Hopefully now the doubt has been resolved. Now you're not going to repeat the same mistake in the examination, please. ठीक है? Next is question number 47. A male neonate was brought to you with complaints of decreased urinary flow and complains that the child cries while micturating. Mother gives a history of fever and urine analysis reveals there is pus cells. Obviously, we know whenever they bring a male neonate with complaints of poor stream of urine or decreased urinary flow, and then the child is crying while micturition, the child is having UTI or urinary tract infection, you will be like, how UTI? They have said there is fever, they have said that the pus cells are seen on urine analysis, so that means the child is having UTI. Why? Because if you do a ultrasound KUB, you are able to see the child is having hydronephrosis. We know yesterday itself we have discussed hydronephrosis is urine retention which will cause dilatation of pelvis and callisis in kidney. That is hydronephrosis. So ultrasound shows hydronephrosis due to retention of urine. There is retention of urine even in the bladder. Okay, and the micturating cystourethrogram or the MCU picture has been given below. Now they're asking you what is the definitive management. Okay, now they're asking you what is the definitive management or the final management. So here, if you see the case, we know there is a male neonate having decreased urinary frequency, UTI, along with hydronephrosis. And if you do a micturating cystourethrogram, a very classical appearance called as the keyhole appearance, right? A micturating cystourethrogram giving you a very classical keyhole appearance. I hope all of you are quite aware. This is nothing else but a diagnosis of PUV beta, that is a posterior urethral valve, right? The diagnosis of this case is nothing else but it is a case of posterior urethral valve. So whenever there is a valve in the posterior urethra of the male neonate, you will be able to have this kind of a clinical picture where they will say decreased urinary stream or decreased urinary flow, urine retention causing recurrent UTI. That is a classical presentation of posterior urethral valve. We know in PUV cases, investigation of choice is MCU or micturating cystourethrogram, which shows you the classical keyhole appearance that confirms your diagnosis. Now they're asking you what is the definitive management. See, if they would have asked me what is the next step or what is the immediate management, so the next step or immediate management would be option C, that is insertion of Foley's catheter. So first line treatment would be option C, that is insertion of Foley's catheter. Reason, as the child is having urine retention beta, the first step is basically to drain the urine. Okay, that is done by option C, that is insertion of Foley's catheter. That would be my first line treatment. If Foley's catheter insertion is not possible, which is usually rare, then we go for a suprapubic catheterization or a suprapubic cystostomy beta, SPC we call it as. Clear? Urine culture you may send, but that is not a priority basically, okay, because there is not a current UTI, they are saying history of UTI is there. Clear about? So that is what is important. Okay, and any which ways they have not asked about what is going to be done next, they have asked about what is the definitive management. The answer has to be option D, that is known as a TURV, TURV we call it as, that is transurethral resection of valve, or nowadays with the help of laser we can do a transurethral fulguration of valve. So either a transurethral resection of valve or fulguration of valve is going to be the best treatment or the definitive management that we do in a patient of posterior urethral valve. Clear? This is where you tend to get confused in surgery and obs and gynae. Definitive, next step, next best step. तो यहाँ गड़बड़ मत करना प्लीज. Clear? अभी कोई दिक्कत नहीं थी इस क्वेश्चन में. Hopefully PDF I'll share after the session once I've annotated the PDF in my Telegram group. You'll find it. ठीक है? Next is the question which says we are having a 16-year-old male who presents to the surgery emergency beta with complaints of sudden onset right iliac fossa pain along with fever and anorexia, that is loss of appetite. Assessment with Alvarado score, we know Mantral score also known as the Alvarado score is used, and they are saying the assessment of Alvarado score shows a score of 9 totally. I hope all of you are quite aware about the Alvarado score. See, if I talk about the Alvarado score, this Alvarado score is also known as the Mantral scoring system. Mantrals is basically an abbreviation of all the parameters that we use in the Alvarado score. Okay, Mantrals is an abbreviation of all the parameters. If I talk about Mantrals, M basically stands for the migratory right iliac fossa pain, or you can call it as the right lower quadrant tenderness. That is basically given. So please remember, See, here definitely M for basically the migratory right iliac fossa pain or migration of pain to the right lower quadrant of the right iliac fossa. That is usually given a score of 1. Next important, A stands for anorexia. Anorexia is given a score of 1. N for nausea and vomiting. That is going to be given a score of 1. T for, this is important, that is T for tenderness. So whenever there is a tenderness in the right iliac fossa or the right lower quadrant, that is given a score of 2. Next, R for rebound tenderness or rebound pain. Rebound tenderness or rebound pain is given a score of 1. And next is E for elevated temperature of fever. Elevated temperature of fever is given a score of 1. L for leukocytosis or increased WBC count. So leukocytosis or increased WBC count basically usually more than 11,000, not exactly 10. That is going to be given a score of 2. And lastly, S for shift to left beta. Okay, S basically for shift to left. That means there will be more amount of neutrophils and especially immature neutrophils will be more. That's the reason we call it as shift to left, and that is given a score of 1. Do remember, whenever the patient's Alvarado score or Mantral score is less than 5, it is not likely or it is unlikely of appendicitis. But whenever the patient score is more than equal to 7, it is suspicious or it is suggestive of appendicitis. Yaad rakhna, whenever the patient's Mantral score is more than equal to 7, it is suspicious of appendicitis. Whereas whenever the patient score is 5 or 6, it is equivocal. That means there are 50-50% chances. Whenever the patient's Mantral score is 5 or 6, there is equivocal chances or 50-50% chances. It may or may not be appendicitis. Here, though, they are saying the score is 9. That means it is strongly suggestive or it is almost certain of appendicitis. But they are saying after this, the patient refuses the treatment but has been brought to the emergency department again after 3 days. And now on palpation, it reveals there is a lump inside the right iliac fossa. Which among the following is the most appropriate management for this case? If they ask you options, so we know basically beta, the options are option A, that is Ochsner-Sherin regime, which is a conservative management. Option B is an emergency appendectomy. Option C is an extraperitoneal drainage. Option D is a exploratory laparotomy. So please tell me what is going to be the treatment in this condition. Very good, Shabash. So I hope all of you are quite aware. As soon as they mentioned this one, that there was a lump palpable in the right iliac fossa, we know if there is lump palpable inside the right iliac fossa, that means the diagnosis is not only appendicitis now, the diagnosis becomes appendicular lump. An appendicular lump forms due to adhesions. So whenever there are going to be adhesions, beta, that is the reason why a appendicular lump is going to develop. Right, so due to inflammation there were adhesions and adhesions की वजह से the patient basically had a lump in the right iliac fossa. Hopefully clear. And whenever there is a lump, the treatment is option A, that is the Ochsner-Sherin regime, which is a conservative management. And conservative management, we all know it is keep your patient NPO or nil per oral, give IV fluids, IV antibiotics and analgesics to the patient. That's it. So conservative management or Ochsner-Sherin regime is done. And when we give Ochsner-Sherin regime, we have to monitor our patient beta. If our patient's condition improves, then we have to discharge our patient and we will call back our patient after 4 to 6 weeks and go for an interval appendectomy or interval appendicectomy. Whereas if the patient's condition is going to worsen, if the patient's condition worsens, then we have to think about a diagnosis of appendicular abscess. And if it is a diagnosis of appendicular abscess, then the treatment will be an extraperitoneal drainage. Hopefully clear. So do remember, emergency appendectomy would have been done beta if the patient was having appendicitis and if there was a immediate risk of perforation, like in pregnancy. This was a case, appendicitis in pregnancy is treated by, answer would be an emergency appendicectomy. Whereas if they ask you extraperitoneal drainage, we know it is done for appendicular abscess, and exploratory laparotomy is done in case of perforation. If there was a case of an appendicular perforation, then we would have gone for an exploratory laparotomy. Do remember, if I talk about the abdominal incisions that we use, so for a case of an appendectomy, the abdominal incisions that we use are mainly, one is the McBurney's incision and second is the Lanz incision. Do remember, McBurney's is a oblique incision in the right iliac fossa beta, almost at the McBurney's point. McBurney's incision is of two types we know. The muscle splitting incision is known as gridiron. The muscle splitting is known as gridiron, whereas the muscle cutting one is known as Rutherford-Morrison. The muscle cutting one is known as Rutherford-Morrison. Whereas Lanz incision is a horizontal or a transverse incision in the right iliac fossa. It is a muscle splitting variety. So Lanz incision is a horizontal or a transverse incision, muscle splitting variety in the right iliac fossa. Clear? These are the two incisions generally used for appendectomy or appendicectomy. Whereas we know in the midline of the lower abdomen, if there is an incision called as Phanencesteal incision or a bikini incision, this Phanencesteal or bikini incision is generally used for urinary bladder operations or LSCS. For urinary bladder operation or LSCS, you use the Phanencesteal incision. Next, if there is a midline incision in the abdomen, sparing the umbilicus, the midline abdominal incision sparing the umbilicus, then it is an incision used for laparotomy. So whenever we have to do an exploratory laparotomy, we tend to use the midline incision. Next, in the right hypochondrium or in the right upper quadrant, if you are going to make an oblique incision, that is known as Kocher's incision used for a open cholecystectomy. So open cholecystectomy is done with a Kocher's incision and oblique incision in the right upper quadrant. Hopefully clear to all of you. At least remember these are the important ones. Clear? Next is question number 49. We are having a patient who has presented to your OPD with complaints of an episodic headache along with palpitations and diaphoresis. We know this is a classical triad that is episodic headache along with palpitations and excessive sweating called as diaphoresis. They are saying that CT scan reveals there is a retroperitoneal mass in the left lumbar region. So retroperitoneal mass in the left lumbar region and urinary levels show there is elevated metanephrines. So urinary metanephrines were found to be elevated. We know as soon as they say there is a retroperitoneal mass in the lumbar region and urinary metanephrine levels are going to be elevated, we surely know it is a classical case of which condition. You can see this is a retroperitoneal mass which is seen, okay, that is seen above the kidney. So it is basically a tumor that is arising from the adrenal gland beta and a tumor that arises from adrenal medulla causing headache, palpitations and diaphoresis along with urinary metanephrine levels to be elevated is a classical case of pheochromocytoma. We know that pheochromocytoma majorly arises from the adrenal medulla and it is going to secrete a lot of catecholamines like epinephrine, norepinephrine and dopamine. And these catecholamines like epinephrine, norepinephrine and dopamine are the reason why patient has symptoms like palpitations, diaphoresis or hypertension. And we know pheochromocytoma is basically known to follow rule of 10 beta. Like rule of 2 is followed by Meckel's diverticulum, rule of 10 is followed by pheochromocytoma. That is, only 10% cases are malignant, 90% are benign. Only 10% cases are bilateral, 90% are unilateral. Only 10% cases are seen in children, 90% are seen in adults. And only 10% cases are extra adrenal, which arise from the sympathetic chain. Otherwise, 90% arise from the adrenal medulla itself. Clear? That is important to be remembered. We know in cases of pheochromocytoma, the investigation of choice that we have is known as plasma fractionated metanephrine. Okay. We know that screening test can be urinary metanephrine levels, but investigation of choice is plasma fractionated metanephrine levels beta. Whereas investigation of choice to localize the tumor is MRI abdomen. Investigation of choice to find the tumor or to localize the tumor is an MRI abdomen that has to be kept in mind. The treatment of pheochromocytoma is usually a surgery. We have to take the patient for surgery if there is a benign pheochromocytoma. But before the surgery, preoperative hypertension is managed by a drug known as oral phenoxybenzamine. This has been a repeated PYQ. Preoperative hypertension and pheochromocytoma is managed by oral phenoxybenzamine, whereas intraoperative hypertension during surgery is managed by IV phentolamine. The intraoperative hypertension during surgery, it is managed by IV phentolamine beta. That has to be kept in mind. याद रखना, if they ask you they are asking you which among the following statement will be true about pheochromocytoma, a recent NEET PG question, do remember, which was completely based on rule of 10 of pheochromocytoma. Let me know in the chat box what is your likely answer. I have discussed the rule of 10 with you. So I hope now all of you are quite aware about the answer. Here they are saying option A says majority patients will have a bilateral mass. No beta. Option A is wrong. We know majority patients have a unilateral mass. As I've told you, 90% case have a unilateral mass. Only 10% have a bilateral one. Option B says 85% cases will be malignant in nature. No. उल्टा है. I have told you that only 10% cases are malignant. Almost 85 to 90% cases are benign in nature. Option C says mainstay of management is antihypertensives. No. Antihypertensives are just used to manage the hypertension. Mainstay of management is surgery or a surgical resection of the tumor. So we know answer is option D, beta. That is nothing else but is it associated with the MEN2A syndrome? We know MEN is multiple endocrine neoplasia. So yes, it is associated with the MEN2A syndrome, also called as Sippel syndrome, beta. And this MEN2A syndrome or Sippel syndrome is commonly associated with red gene mutation. So we know the medullary thyroid cancer and pheochromocytoma. Medullary thyroid cancer and pheochromocytoma, these are the two main tumors associated with red gene mutation, and as they are due to red gene mutation, they can be associated with MEN2A as well as MEN2B syndrome. MEN2A, that is Sippel syndrome, and MEN2B, that is Gorlin syndrome. Clear? Next is question number 50. It states we are having a 55-year-old male beta who came to the OPD with swelling in the left scrotal region along with pain. So there is a swelling in the left scrotal region along with pain. Pain increases on standing, they say, and it is usually seen in the evening time, beta. On palpation, it feels like a bag of worm. So we know it is a very classical hint, bag of worm feel. That proves your diagnosis itself, right? What is the most likely diagnosis? So I hope all of you are quite aware. Whenever the patient is going to have swelling and pain in the scrotal region, along with that, there is a bag of worm feel. No doubt at all. It has to be a diagnosis of nothing else but option D, that is a varicocele. And we know whenever there is a case of a varicocele, it is due to dilatation of the pampiniform plexus of veins. So we know varicocele is what? Whenever there is collection of blood or whenever there is pooling up of blood in the pampiniform plexus of testicular veins, these pampiniform plexus of testicular veins are dilated, and these dilated pampiniform testicular veins, they will give you a bag of worm feel. That is what is known as varicocele. Yaad rakhna, as it is a vascular condition, investigation of choice is the Doppler scan. Investigation of choice is Doppler scan. That has to be kept in mind. And treatment, if they ask you, so yaad rakhna, treatment in patients of varicocele, either you can go for an angioembolization, or basically you can go for a surgical ligation. Okay, whichever vessels are having blood pooling beta inside them, you can either embolize them by the process of angioembolization, or you can surgically ligate them, or you can use a sclerotherapy also. But if they ask you what is the best treatment for varicocele, so yaad rakhna, the best treatment for a varicocele is a varicocelectomy. You have to excise, the dilated veins from the pampiniform plexus, and that excision of the dilated veins from the pampiniform plexus is known as varicocelectomy. That is the best treatment. Okay. Option A says inguinal hernia. Inguinal hernia is commonly a painless swelling. Okay, and it is an inguinoscrotal swelling, not only a scrotal swelling. That is what is important to be remembered. Okay, and do remember, it does not give any bag of worm feel. It may give you a doughy feel, आटे जैसा feel देगी वो, not a bag of worm feel. Testicular torsion, it is commonly seen in younger males, and it does not cause any bag of worm feel again. It rather causes a severe pain. And epididymal cyst, again, epididymal cyst does not give you a bag of worm feel. It basically gives you a bunch of grape-like appearance or a bunch of grape feel. So if they talk about a bunch of grape-like appearance or a bunch of grape feel, then I would definitely think about a epididymal cyst as my diagnosis. Clear? Chalo. And do remember, varicocele is always common on the left side. So most commonly you will find that varicocele is left sided always, because of the improper drainage or inadequate drainage of the left testicular vein. Okay? Question number 51 now. It states a child has been brought to you with complaints of respiratory distress along with choking, and x-ray done has been given below. What is the appropriate treatment? So here you can see, first of all, we know whenever there is a foreign body in the x-ray, we go for a, whenever there is a foreign body, we have to go for an x-ray. We have to do a x-ray AP view as well as the x-ray lateral view. Commonly the foreign body is a coin, or it is going to be a desk battery or peanuts. So we know if the coin or if the foreign body appears slit like on the AP view, you can find it is appearing slit like on the AP view or circular on the lateral view. That means the location of the foreign body is inside the trachea. So we know slit like on the AP view and circular on the lateral view. That means the location of foreign body is the trachea. But whenever the foreign body appears circular on the AP view, as you are able to see, whereas slit-like on the lateral view. So whenever the foreign body appears circular on the AP view and slit-like on the lateral view, that means the location of foreign body is the esophagus. Here you can see that the foreign body which is there, it is appearing slit-like on the AP view, and I hope all of you are quite aware, whenever the foreign body appears slit-like on the AP view, that means the location of foreign body is inside the trachea. So here definitely it is a case of a tracheal foreign body. And we know whenever the foreign body is in the airway, does not matter whether it is inside the larynx, trachea or bronchi. Okay, anywhere if the foreign body is present inside the airway, the management is always an endoscopic removal. You cannot keep the foreign body in the airway. Otherwise, the patient will have choking and respiratory distress. So as the patient is having respiratory distress or choking, here definitely the answer is option B. You have to immediately go for a tracheoscopic or an endoscopic removal. As the foreign body is in the airway, you have to go for option B, tracheoscopic or an endoscopic removal. Do remember, if the foreign body was inside the esophagus, then you have to see the location, whether it is above the C6 or it is below C6. If the foreign body would be above C6, then we go for an endoscopic removal. But if the foreign body is below C6, then we have to go for an observation or wait and watch. Clear about? And we will wait for the foreign body to come out on its own. So we would have gone for esophagoscopic removal if the foreign body was inside the esophagus and present above C6. We would have gone for wait and watch or observation if the foreign body was inside the esophagus and below C6. Clear? CECD chest is not usually done. And do remember, if they talk about what is the most common location of foreign body inside the lungs, this has been a PYQ from anatomy also. The most common site for foreign body inside the lungs, answer is the right lower lobes. Reason, do remember, the right sided bronchus is wider and more straight. Okay, that's the reason commonly the foreign body lodges in the right lower lobes of lung. Clear about that is important. We know why what is the most common site for obstruction of foreign body. The most common site for the enlarged, like most common site for the impaction of the foreign body is at the level of C6. That means at the level of the cricopharyngeal sphincter. We know this cricopharyngeal sphincter is located at the level of C6 and it is the narrowest portion of the whole GIT. So the narrowest portion of the whole GIT, we know it is going to be the cricopharyngeal sphincter at C6. So usually they tend to ask you questions on these esophageal constrictions and the distance from the upper central incisors. This has to be remembered. So there are 4 constrictions in the esophagus. The first constriction is at the level of cricopharyngeal sphincter, which is at the level of C6 and it is 15 centimeters from the upper central incisors. Second constriction is basically due to the aorta. So the second one is an aortic constriction which is at the level of T4 and that is 25 centimeters from the upper central incisors. Third constriction is due to the bronchus. So the left main bronchus causes the third constriction and this bronchial constriction is at the level of T5 and it is around 28 centimeters. So 27 to 28 centimeters from the upper central incisors. And lastly, the fourth constriction is at the level of T10. This T10 pe we have the diaphragmatic constriction. Okay, when the esophagus crosses the diaphragm, at that site you are having the diaphragmatic constriction at the level of T10 and that is going to be 40 centimeters from the upper central incisors. Hopefully clear. Recent question in NEET PG is they said there was a constriction that was 27 to 28 centimeters away from the upper central incisors. This constriction is due to, so we know this constriction is due to the left bronchus beta. That was a recent question in the NEET PG examination. We know there can also be one more foreign body. Here you can see, if you see the AP view of the X-ray beta, you are able to see not one but rather 2 rings. And whenever the X-ray is going to show you 2 rings, that is called as the double ring sign. ठीक है, तो X-ray AP view is showing you the double ring sign. Second, if you see the borders, you will find there is a beveling or an oblique edge, right? If you see the lateral view, you are able to see an oblique edge that is called as beveling. So whenever AP view shows you a double ring sign and the lateral view shows you beveling, we know this foreign body is nothing else but a disc battery or a button battery. This foreign body is classically a disc battery or a button battery. And whenever the foreign body is a disc or a button battery, the treatment is nothing else but you have to go for an urgent endoscopic removal irrespective of the location. Yes, does not matter what is going to be the location of the foreign body, whether it is in the airway or the esophagus. In esophagus, above C6, below C6, does not matter. Disc battery or foreign battery hai, so we know there will be a risk of perforation. That's the reason it's better to go for an urgent endoscopic removal. Hopefully clear. Chalo. Next important is question number 52 now. Here they are saying we are having a chronic alcoholic patient who is a known case of chronic liver disease, and this patient presents to the casualty with complaints of hematemesis. Now they are asking you what is the most probable diagnosis. Now this is very clear, the third condition. Okay, so whenever there is a chronic alcoholic patient, they say, and he is suffering from a CLD or a chronic liver disease, and now comes to you with complaints of upper GI bleeding or hematemesis. What is the provisional diagnosis? So we know this is a case of chronic liver disease or cirrhosis. So in patients of cirrhosis, the patient will develop a portal hypertension. Do remember, portal hypertension mein the pressure is going to be more than 5 millimeters of mercury. So pressure more than 5 millimeters of mercury cause portal hypertension. And due to that, the pressure in the lower esophageal vessels will increase. And if the pressure in the lower esophageal vessels increases, that is known to cause esophageal varices. And when these esophageal varices will rupture, that is going to cause the upper GI bleeding or hematemesis. So it is a very classical case of esophageal varices that has to be kept in mind. हमें पता है that esophageal varices which are there, they basically form at a pressure of more than 10 millimeters of mercury, and they usually bleed at a pressure of more than 12 millimeters of mercury. That has been a question. So portal hypertension more than 5, formation of varices more than 10, and bleeding of varices more than 12 millimeters of mercury. These are the three pressures to be remembered. Hopefully clear about. And do remember, this is a classical diagnosis of option C, that is bleeding esophageal varices. Do remember, Mallory-Weiss tier mein they would say a patient is a chronic alcoholic, but I've told you they would give you a history of binge drinking or binge eating and repeated episodes of vomiting or retching. Nothing of that sort has been given over here. Boerhaave syndrome mein again the same history of a chronic alcoholic, but with a history of binge eating or binge drinking with multiple episodes of vomiting or retching. Okay, so that is important. Acute gastritis, here acute gastritis may they would definitely give you a previous history of epigastric pain or something. Here they have given you a known case of CLD, so therefore the more common diagnosis becomes esophageal varices. Hopefully clear. We know whenever a patient is brought to you with esophageal varices, you can go for an upper GI endoscopy which shows you these dilated varices. And the first step in management, any case who comes to you with ongoing bleeding, the patient may be hemodynamically unstable, therefore go for basic resuscitation or give IV fluids to the patient. Followed by which the drug of choice can be either give an IV octreotide or a terlipressin beta. Okay, either give a octreotide or terlipressin for the management. If that fails, then you have to go for banding or sclerotherapy. If medical management fails, go for banding or sclerotherapy. And if banding or sclerotherapy also fails, the last treatment in patients of esophageal varices is TIPS. The last treatment in cases of bleeding esophageal varices is TIPS, that is transjugular intrahepatic portosystemic shunt. Okay, it is known as transjugular intrahepatic portosystemic shunt when a shunting is done between portal and hepatic veins. Till the shunting or till the surgery is done, we can stop the bleeding or we can control the bleeding with the help of these tubes. Single balloon is the Linton's tube. Double balloon, okay, with three ports. Double balloon with three ports is the Sengstaken-Blackmore tube, which was a PYQ in the FMGE examination as an image-based question. Sengstaken-Blackmore tube has two balloons and three ports, whereas two balloons but with four ports, two balloons and four ports is the Minnesota tube. Clear? Now please tell me, what is the drug of choice for prevention of esophageal varices? Future episodes should not happen. What is the drug of choice for prevention of esophageal varices? What is the drug you should give so that the patient does not come to you with a recurrence or a bleeding again? So I hope all of you are quite aware. The drug of choice for the prevention of esophageal varices is a beta blocker known as propanolol, right? So the drug of choice which will decrease the pressure is known as propanolol. So propanolol is the drug of choice for prevention in esophageal varices. Hopefully clear. Chalo. Next important, now let's talk about question number 53. This is a question which says a patient has undergone the below given surgery. Let me know the name of the below given surgery beta in the chat box. Okay, I want you all to tell me about the name of the surgery. So they are saying that the patient has undergone the below given surgery for the purpose of weight loss. So we know any surgery that is done for the purpose of weight loss, it is known as a bariatric surgery or a metabolic surgery. So we know this is a type of bariatric or metabolic surgery done, and now the patient starts complaining of fatigue along with tingling sensation in the periphery. What is the likely nutrient supplement which would help improve the patient's condition? ठीक है, so if they ask you which among the following nutrient supplement will improve the patient's condition beta, ठीक है, nutrient supplement which will help in improving the patient's condition, we'll talk about that. But first of all, this bariatric surgery that you can see what we have done here, we have connected the jejunum directly to the esophagus or directly to a gastric pouch beta. Why? So that the food goes into the jejunum directly. That means the food should bypass the stomach, and if the food will bypass the stomach, obviously the patient's appetite will be less. Okay, so if the food is bypassing the stomach, the patient's appetite is less. If he tries to eat a lot of food, he will develop early dumping syndrome. That's the reason patient avoids eating a lot of food, and as appetite of the patient decreases, eventually the patient will have weight loss. Clear? And this is classically known as the Roux-en-Y gastric bypass surgery, which we know is the most effective surgery for weight loss or most effective surgery in bariatrics. So if they ask you best results are seen with, so we know the best results are going to be seen with the Roux-en-Y gastric bypass surgery. But obviously it is not the most common surgery done for bariatric. We know the most common done, the most commonly done surgery in bariatrics is sleeve gastrectomy. ठीक है, तो bariatrics में at least remember two surgeries. One, the best one with best results is Roux-en-Y gastric bypass surgery, but the most common one is a sleeve gastrectomy. Okay, we know whenever a patient will undergo a bariatric surgery or whenever a patient undergoes a gastrectomy for a cancer, for ulcer, whatever reason, or the patient undergoes ulcer surgeries like a Bilroth surgery for gastric ulcers or a vagotomy for duodenal ulcers. Bilroth surgery for gastric ulcers or vagotomy for duodenal ulcer. Any of these surgery, याद रखना, कोई भी हिस्ट्री हो, bariatric surgery, gastrectomy or ulcer surgery, any of this history, the most common nutrient deficiency remains iron followed by vitamin B12. Most common nutrient deficiency will be iron because acidic medium will not be there or the food will bypass the duodenum. Either of that reason, due to which iron is going to be the most common nutrient deficiency, which will cause an iron deficiency anemia, followed by vitamin B12 or cobalamin. Now, please tell me in our case, what is the nutrient supplement we should give to a patient which will help improving his condition? What is the nutrient supplement we should give our patient basically so that the patient's condition improves? Which let me know in the chat box. Which nutrient supplement should be given to our patient so his condition improves? I hope all of you are quite aware. Very good. We know that here, if they would have only mentioned about fatigue, I would have considered it as anemia and I would have gone for iron supplements. But along with fatigue, they're also saying tingling sensation. And we know tingling sensation is a sign of peripheral neuropathy. We know iron deficiency can cause anemia or fatigue, but iron deficiency does not cause any tingling sensation. If they're also saying tingling sensation, that means it is a case of vitamin B12 or cobalamin deficiency. So that's the reason why option B or giving vitamin B12 supplements will help improve the patient's condition. Okay, in vitamin B12 deficiency, patient develops a megaloblastic anemia which will cause fatigue and patient develops peripheral neuropathy which is causing tingling. So if both features are there, think about vitamin B12 deficiency, and that's the reason vitamin B12 will be the answer. Okay, so that is the reason why iron is not the answer. Calcium supplements and vitamin D supplements are also given after these surgeries. Yes, apart from iron and vitamin B12, the third most common nutrient deficient is calcium and vitamin D. That supplement should also be given to this patient. Folic acid is not usually deficient. ठीक है, चलो. Next is question 54. Here they are saying we are having a 40-year-old female who presents to you with a complaint of a slow growing breast lump which is around 5 by 4 centimeters in size, which is mobile. On examination, there is a bosselated appearance and skin color changes are going to be seen. They are saying true cut biopsy was done and the histopathological image has been given below. What shall be the treatment in this case? So do remember, whenever there is a female in third or fourth decade of life, along with a breast lump, okay, like which is mobile basically, okay, she's having a breast lump which is going to be mobile and it is giving you a very classical bosselated appearance or skin color changes. I hope all of these features itself are enough to make a classical diagnosis of nothing else but phylloid tumor. We know it is a mesenchymal breast tumor beta called as phylloid tumor, also called as cystosarcoma phylloids. We know majority cases of phylloid tumor are going to be benign in nature and benign phylloids is going to be mobile. Yes, it is not as freely mobile as the fibroadenoma, but mobile matlab fibroadenoma is not always true. Sometimes even a phylloid tumor will be mobile also, so be aware of that point. Clear? Benign phylloids are usually mobile because they are superficial. And do remember, in cases of phylloid tumor, bosselated appearance and skin color changes are going to be seen beta, which are not a feature of fibroadenoma at all. Clear? Histopathology confirms your diagnosis. Recent NEET PG, this was the histopath given. You are able to see on the histopath there is a classical leaf-like structures which are going to be present, right? So here you are able to see a histopathology showing you a leaf-like structure. So whenever the histopathology shows us leaf-like structures, we know it is a sure short case of phylloid tumor itself. And if it is a case of phylloid tumor, we know investigation of choice is true cut biopsy, which shows us the leaf-like structures, and treatment. If it is a benign phylloid tumor, so we know the treatment should be option D, that is a wide local excision. If it is a case of a benign phylloid tumor, my answer has to be option D, that is a wide local excision or only removal of tumor to be done. If it is a case of a malignant phylloids, or if it is a case of a large phylloids beta, if it is a case of a malignant phylloids or a very large phylloid, only in those conditions you should go for a simple mastectomy. If it was a malignant, large or a recurrent phylloid, then my answer would have been option A, simple mastectomy. Yes, radical mastectomy is never done for phylloids. Reason, phylloids does not spread by a lymphatic or hematogenous route. We know that, right? So that's the reason radical mastectomy is never required for phylloids. Low dose tamoxifen is not given here. Hopefully clear to all of you. So here it seems to be more likely a case of benign phylloid tumor, and that's the reason we have to go for a wide local excision as the treatment. Here, if this is the histopath, here you are able to see there is a lot of fibrous trauma and the glandular tissues or the glandular structures appears to be compressed. And as the glandular structures are compressed, they are looking like the horns of a reindeer or they are looking like the horns of an antler. So here the histopath of the breast lump shows you the classical antler sign beta. It shows you the classical antler sign, and we know whenever antler sign is going to be seen on histopath, it has to be a case of fibroadenoma, which is the most common benign breast tumor. It is going to be a case of a fibroadenoma, which is the most common benign breast tumor. Do remember, fibroadenoma is commonly seen in younger females, especially those who are between 15 to 25 years of age. Secondly, fibroadenoma is a painless lump which is freely mobile. And as fibroadenoma is so freely mobile, we know we call it as a breast mouse as well. याद रखना इन fibroadenoma investigation of choice is an ultrasound. Yes, in a fibroadenoma the investigation of choice is an ultrasound. If the Bariatric score is 4 or 5, if the Bariatric score is 4 or 5, only in those conditions we need a FNSE or biopsy. Otherwise, the FNSE or biopsy is not done. Treatment for majority fibroadenoma is observation and follow-up. The only treatment for a case of fibroadenoma is just observation and follow-up to be done, nothing else. Okay, surgery can be done in few cases of fibroadenoma, and a PYQ was what is the most common indication or what is the most common reason for doing a surgery in fibroadenoma. So surgical excision in fibroadenoma is most commonly done due to cosmetic indications. डॉक्टर साहब अच्छा नहीं लगता है, ठीक है, only due to cosmetic indication we commonly go for surgery. Other reasons are malignant conversion or a giant fibroadenoma. Clear? चल next. Question number 55. A Sarkari question repeated very commonly in the FMG as well as NEET PG exams, especially in FMG exams. We know they are asking you to identify this instrument, and if you see this instrument, this is a needle beta which is having a screw over here, and secondly, this needle is having a valve. Apart from that, it is also having beveled edges. So whenever there is a needle which is having a valve along with beveled edges, I hope all of you are quite aware. It is a classical picture of option B, that is a varus needle. Then it is a classical case of varus needle. याद रखना varus needle is generally used to create pneumoperitoneum. So whenever we want to perform a laparoscopic surgery, we have to create pneumoperitoneum, or we have to fill gas inside the peritoneal cavity. So to create a pneumoperitoneum during a laparoscopic surgery, we tend to use the varus needle, and the most common gas that we use for creating pneumoperitoneum during laparoscopic surgery is CO2 gas or the carbon dioxide gas. The commonest gas that we use to create pneumoperitoneum during a laparoscopic surgery is a CO2 or a carbon dioxide gas. Do remember that. We know Tovey's needle or Quincke's needle are used for delivering or giving anesthesia. याद रखना, these three needles that you are able to see over here, these three needles, the first one is basically the Quincke's needle, second one is the Whitaker needle, and the third one is Proti needle. Quincke was a previous year image based question in August 2020 FMG. So Quincke, Whitaker and Proti, these three needles are generally used for a spinal anesthesia. So Quincke, Whitaker and Proti, these are the three needles that are generally used for spinal anesthesia, and we know the last layer that is pierced in spinal anesthesia is the arachnoid matter. The last layer pierced during a spinal anesthesia is the arachnoid matter. Next, this is the Tovey's needle. And do remember, Tovey's needle is the needle used for epidural anesthesia. Tovey's needle is the needle used for epidural anesthesia. And the last layer that is pierced during an epidural anesthesia is ligamentum flavum. Last layer pierced during an epidural anesthesia, we know it is ligamentum flavum. Hopefully clear to all of you now. Do remember this point. And this is the picture of a Jamshidi needle, beta. This is the picture of Jamshidi needle. You might have discussed in pathomedicine. This is the needle that is commonly used for bone marrow biopsy. So we know if you want to do a bone marrow biopsy, the needle that we tend to use is known as Jamshidi needle. The Salah and the Kleima needle are used for bone marrow aspiration. Salah and Kleima needle are used for bone marrow aspiration, whereas Jamshidi needle is generally used for bone marrow biopsy. Hopefully clear. So do remember this point. Varices is the commonest question from needles that comes in the exam. Next, this is the picture. Easy one. I hope all of you are quite aware about this condition. Let me know in the chat box. Okay? So hopefully you are all quite aware about this. Clear about? So here they are saying question number 56, and that is a neonate has been brought to the surgery department, beta, with the below given finding. What is this below given finding that you are able to see? Along with the complaint of pubic diastasis is there. Identify the congenital anomaly which is seen over here. Identify the congenital anomaly which is seen. So I hope all of you are quite aware this neonate is not having the fusion of the pubic bone, that is known as pubic diastasis. That is one point. Second important, you will see that the urinary bladder is exposed. Okay, the anterior abdominal wall is deficient over here, and that's the reason the urinary bladder is directly exposed to the external environment. Okay, and this is a classical condition, option C, that is a bladder extrophy, also called as ectopia vesicae. We know this condition is classically known as bladder extrophy, also called as the ectopia vesicae, beta. That is what is very very important for the examination to be remembered. Commonly repeated in FMG and NEET PG both. This has been a case, to be aware of that. Okay. Okay, no issues with this. Do remember the other conditions, gastrochoices and omphalocele, are the defects in the abdominal wall but not related to the bladder. Okay. Urachus fistula, in that condition, urine comes out from the umbilicus of the patient. Okay, so that is important. So here you can see the first picture. You are able to see this is a umbilical defect which is very large in size, and as it is large in size, not only the bowel but even other organs like liver are also herniating. Second, you are able to see a peritoneal sac or a peritoneal covering is going to be present, whereas this condition is commonly associated with Beckwith-Widman syndrome. We know this is a classical case of an omphalocele. This has been a previous year question in the examination. This one is a classical case of an omphalocele that has to be kept in mind. Hopefully all of you are quite aware. That is one thing. Second important, if I talk about, is this picture over here where you are able to find a paraumbilical small defect. So this is a paraumbilical defect which is smaller in size, and that's the reason you will be able to see only the bowel or the intestine is herniating. There is no other structure that is herniating. So here this is besides the umbilicus or just side of the umbilicus, Usually, okay, there is a paraumbilical small defect which is seen, only intestines or bowel herniating. There is no covering or no peritoneal sac which is there. And this condition is not commonly associated with any congenital anomaly. We know this congenital anomaly is classically known as gastroschisis. This congenital anomaly which is there, it is very classically called as the gastroschisis. That has to be kept in mind. No issues with this, anybody? Chalo. So these are the points that you need to remember. Understood? Next important is, if I talk about question number 57. Yaad rakhna, here there is a case which a lot of people are confused about. I'm not sure why, but it is easy. Do remember, here we are having an elderly patient who suffered from burns. And now on assessment, you are able to see there are 10% first degree burns along with 20% second degree deep burns, 10% full thickness burns. Full thickness burns means third or fourth degree burns. His weight was 60 kg. Blood pressure was 100 by 60 millimeters of mercury. Pulse rate was 110 beats per minute. How much amount of fluid they are asking you? That how much amount of fluid shall be given to this patient while resuscitation is going on in the initial 8 hours using the ATLS formula or the ATLS guidelines. So if I talk about ATLS or advanced trauma life support, I hope all of you are quite aware. It has a different formula for adult, child and electrical burns. So whenever you tend to use the ATLS formulas, beta, do remember the adult is going to have a multiplier as 2. That is, for adults we use the formula 2 into body weight into total body surface area of burns. Next, if there is a child who is less than equal to 14 years of age, a child less than equal to 14 years of age, we use the multiplier as 3. That is 3 into body weight into total body surface area burns. Lastly, if there is a case of electrical burns, so in ATLS electrical burns के लिए we use the formula that is 4 into body weight into total body surface area of burns. Whereas if they talk about Parkland's formula, do remember the Parkland's formula is same for any case, beta. Whether it is a adult, child or electrical burns, Parkland formula always remains the same with the multiplier as 4. The multiplier is 4 into body weight into total body surface area of burns if you use the Parkland's formula. Now, whether you use the ATLS or the Parkland's formula, do remember the total amount that you calculate, out of it, the half amount should be given in the first 8 hours, whereas the remaining half amount should be given in the next 16 hours. Okay? So in the initial 8 hours only give half amount, in the remaining 16 hours give the other half amount, basically. That is important. So here they have asked you to use the ATLS formula, and as they say the patient is elderly, so we have to use the ATLS formula of an adult. Okay, and if I use the ATLS formula of an adult, the amount of fluid that we will give to this patient in a total duration of 24 hours will be 2 into body weight into total body surface area of burns. If I talk about body weight of this patient, they have said the body weight of the patient is 60 kg. Please tell me how much is the total body surface area of burns now. Body weight to is 60 kg. How much is the total body surface area of burns if they ask you? So I hope all of you are quite aware. Here Parkland's formula is not commonly used in practice. Parkland's formula is commonly used in practice, but basically ATLS formula, according to ATLS protocol, they are going to use it. Clear? So please remember, here the total body surface area of burns, if they ask you, it is going to be this 20% of second degree deep burns and 10% of full thickness burns. That is 30%. You'll be like, so why not this? Reason, first degree burns are not calculated while we basically calculate the total body surface area of burns for fluid calculation. So fluid calculation ke dauran, we do not consider the first degree burns. And if you calculate this, 2 6 12 12 3 is basically 3600 ml it is going to be. Okay, this is the amount 3600 ml that you have to give to the patient in a total duration of 24 hours, beta. This 3600 ml fluid should be given in a total 24 hours duration. We know out of that half amount of fluid should be given in the first 8 hours. That means option C, 1800 ml of fluid should be given to the patient in the initial 8 hours. As I've only asked you about the initial 8 hours, so only give half fluid basically, that is option C, 1800 ml to be given. No doubt here, the first degree burns are not calculated basically while we calculate the fluid amount in a case of burns, beta. Next, if I talk about question number 58, It states we are having a 50-year-old female recently diagnosed with diabetes, presents to your OPD with the rash as shown below. This has been a repeated question in FMG and NEET PG both. They are saying she is also suffering from depression and she is currently taking medications, beta. Now they're asking you that which tumor is commonly associated with this condition. So I hope all of you are quite aware. A female who is suffering from diabetes mellitus, having a rash, and if you see that along with depression, that is the classical 4Ds. When I say 4Ds, first D is for diabetes mellitus, second D is for dermatitis, third D is for DVT, and fourth D is for depression. Please let me know. These are the 4Ds of which neuroendocrine tumor of pancreas. Let me know in the chat box. We know if they ask you this one, so this rash which is seen over here is a classical case of necrolytic migratory erythema. This rash or this dermatitis that you are able to see, this is classically known as a necrolytic migratory erythema. And we know whenever we are able to find the classical necrolytic migratory erythema, I hope all of you are quite aware, this is going to be a classical case that is going to be associated with, okay, this is going to be a classical case that is going to be associated with nothing else but option B, that is a glucagonoma. We know glucagonoma mein there is excess secretion of glucagon which will increase the blood glucose levels causing diabetes mellitus. Apart from that, patient has dermatitis, DVT and depression also, and the dermatitis or the rash is classically known as necrolytic migratory erythema. Do remember, it is a repeat question. Do remember insulinoma is a tumor of beta cells which will secrete more insulin. So patient will have low blood glucose levels or hypoglycemia, not diabetes. ठीक है? Gastrinoma में patient will have excess gastrin levels causing ulcers. And VIPoma is a tumor of F cells basically where patient has watery diarrhea, hypokalemia and acidosis like features. ठीक है? So that is important. So do remember it is a case of glucagonoma. Serum glucagon levels are used for diagnosis of the patient. Hopefully clear. I hope all of you were clear with this answer. Yes, the classical 4Ds which are seen in patients of the niacin or vitamin B3 deficiency or pellagra. The similar kind of Ds are seen over here. But in that the classical 3Ds are diarrhea, dermatitis, dementia. Here the classical 3Ds are diabetes mellitus, dermatitis and depression. Clear? Next is question number 59. If they ask you a case where they say young patient has undergone a Bilrod 2 surgery for a case of recurrent gastric ulcer. So as the patient was having recurrent gastric ulcer, the patient has undergone a Bilrod 2 surgery which is a gastrojejunostomy. Okay? So whenever the patient undergoes antrectomy plus a gastrojejunostomy, we call it as a Bilrod 2 surgery. After few days of the surgery, they are saying now the patient presents to you with complaints of postprandial epigastric fullness, vomiting, and diarrhea after 15 to 20 minutes of food intake. So after taking the food 15 to 20 minutes later, patient is having problems like postprandial fullness, bloating, vomiting or diarrhea like features. They are asking you what is the likely diagnosis. So I hope all of you are quite aware. Do remember henceforth that whenever a patient has undergone any gastrectomy surgery, any Bilroth surgery, Bilroth 1 or Bilroth 2, or any bariatric surgery like the Roux-en-Y gastrojejunostomy. Do remember after, sorry, Roux-en-Y gastric bypass surgery. After these surgeries, beta, do remember after this surgery, if the patient within 10 to 15 minutes after meals, okay, so 10 to 15 minutes after meals, if the patient is developing symptoms like epigastric fullness, nausea, vomiting, bloating or diarrhea, please remember the diagnosis is going to be a case of an early dumping syndrome. Whereas if this patient 45 minutes to 1 hour after meals, 45 minutes to 1 hour after food intake develop symptoms of rebound hypoglycemia, that is patient has headache, dizziness, palpitations, tremors, diaphoresis, all these features, hypoglycemic symptoms, then the diagnosis will be late dumping syndrome. Clear? So 10 to 15 minutes after food, if there is epigastric fullness, vomiting, diarrhea, think about early dumping. 45 minutes to 1 hour after food, if there rebound hypoglycemia, think about late dumping. Okay? And we know here as the patient was having the symptoms after 15 to 20 minutes and symptoms were like epigastric fullness, vomiting and diarrhea, we know it is a classical case of option B, that is an early dumping syndrome. If there were hypoglycemic symptoms 45 minutes to 1 hour later, then it was late dumping. Recurrence of ulcer will cause epigastric pain, basically not a fullness commonly. Okay, that is what is important. And malabsorption, again no, malabsorption will lead to, if there is iron deficiency, patient will have fatigue, pallor, these kind of symptoms. Treatment: whenever there is a case of a dumping syndrome, does not matter early dumping or late dumping. Advices: you should advise dietary modifications, and in dietary modifications tell the patient to avoid large meals. Do not take large meals. Okay, ज़्यादा खाना एक time पे नहीं खाना है. Ask the patient to avoid any sugar rich foods, or sorry, ask the patient to avoid any sugar rich fluids, something like cola, thumbs up, all of that. ठीक है. Ask the patient to take small and frequent meals. ठीक है, तो थोड़ा थोड़ा खाना खाना है. So these are the things that are done to prevent dumping syndrome after these surgeries. Clear? Next, question number 60, if they ask you, here there is a case which says we are having a 65-year-old patient, and the 65-year-old patient underwent a CABG or underwent a coronary artery bypass grafting, for which the graft was harvested, or the graft has been harvested from the medial aspect of the leg. Now they are saying the patient complains of lack of sensation over the medial aspect of the leg. The patient is having lack of sensations over the medial aspect of the leg as well as the foot, and it is associated with heel pain. We are suspecting an injury to the saphenous nerve, which is the vein that is harvested for the grafting. Two very important hints. First of all, they are saying coronary artery bypass grafting has been done, for which a graft was taken, and that was taken from the medial aspect of the leg. So I hope all of you are quite aware. The vein that is present on the medial aspect of the leg that is commonly used as a graft is known as which one? Let me know. This was a recent question which was asked in a different manner. I've just framed it in a different manner. Okay, the same question. And they are saying that there was an injury to the saphenous nerve during this procedure, basically, or during harvesting this graft. We suspect an injury to saphenous nerve. So I hope all of you are quite aware that the vein that is present on the medial aspect of the leg and the stripping of the vein causing saphenous nerve injury is a classical case of option B, that is a GSV or the LSV, that is great saphenous vein or the long saphenous vein. The answer has to be an option B for this question. Very good. Yes, the answer is option B, long saphenous vein or the great saphenous vein. So please remember, saphenous nerve injury happens whenever we do a stripping of GSV or the great saphenous vein, whereas sural nerve injury happens whenever we do stripping of the short saphenous vein. Okay, याद रखना that great saphenous vein is present on the medial aspect of the leg, whereas short saphenous vein is present on the lateral aspect of the leg. So in a recent image based question in FMG, they marked the medial aspect of the leg and they asked you which vein is located. So we know on the medial aspect we have great saphenous or the long saphenous vein. On the lateral aspect we have the short saphenous vein. Okay, GSV stripping causes saphenous nerve injury and SSV stripping causes sural nerve injury. Do remember both these points. Clear? Chalo. Next is question number 61, which states we are having a 55-year-old female who underwent an open abdominal surgery for the removal of a large ovarian mass. They are saying that she has a past medical history. Okay, there is a past medical history of hypertension along with smoking. There's a past medical history of hypertension and smoking. The patient is on post-operative care and has been advised bed rest. Okay. What is the most effective treatment? They're asking you what is the most effective treatment to prevent the patient from developing DVT or deep venous thrombosis in this case. I hope all of you are quite aware. As the patient has been advised a bed rest, there will be prolonged immobilization, and prolonged immobilization will definitely increase the risk of DVT or deep venous thrombosis. So they are asking you what should be done to prevent the patient from developing DVT or deep venous thrombosis. We know for prevention of DVT, two things are done. One is basically you'll ask the patient to do an early ambulation and mobilization. After the surgery, if you go for an early ambulation and mobilization, that helps preventing DVT. But one thing is that after major surgeries, patient cannot go for an early ambulation. Here they have said patient was advised bed rest. So early ambulation is any which way is not possible and it is not the best method. Next, option B says elastic compression stockings. Do remember, elastic compression stockings are usually prescribed in a case of varicose veins. For DVT, we usually prescribe pneumatic compression stockings. One thing is that. But even if the option was pneumatic compression stockings, I would not have marked option B as the answer. Reason: more effective than the pneumatic compression stockings is an anticoagulant beta. And the anticoagulant is nothing else but option C, injection of low molecular weight heparin. Right? The answer has to be option C. So if they ask you that which is the most effective treatment in preventing DVT, the most effective method to prevent DVT is by giving anticoagulants like low molecular weight heparin, which decreases the risk of DVT at all. Clear? Pneumatic compression stockings may decrease the risk, but it is not as effective as low molecular weight heparin. So even if pneumatic compression stockings were there in option, my answer would still remain low molecular weight heparin. समझे बात? IVC filter placement is basically done to prevent pulmonary embolism. So in a case of recurrent DVT, whenever you want to prevent a problem of pulmonary embolism, at that time you place the inferior vena cava or IVC filter. We know in cases of DVT, prolonged immobilization is the leading cause, and the most common vessel involved are the soleal veins in calf. And as the soleal veins or calf veins are involved, patient has pain and edema in the calf region. Along with that, the two classical clinical signs elicited in patients of DVT. One is the Homan's sign and second is the Moses sign. So Homan's and Moses sign are elicited in DVT. Wells criteria is generally used for predicting DVT. So if you want to predict the chances of DVT in the patient, you use the Wells criteria. Investigation of choice, as it is the peripheral vessels, we know investigation of choice has to be the duplex scan or the color Doppler. And treatment for DVT is an anticoagulation, not prevention, or even the treatment is anticoagulation. So anticoagulation in treatment is done with the help of two anticoagulants. One is the injection of low molecular weight heparin, second is the oral warfarin. So low molecular weight heparin and warfarin both are given basically if you want to prevent a DVT. Hopefully sorry, if you want to treat a DVT. ठीक है? चलो, hopefully clear to all of you now. ठीक है? No issues with this. Great. Next is question number 62. They are asking you, we are having a 3-day-old infant, and this 3-day-old infant is brought to you with complaints of breathlessness shortly after birth. So shortly after birth, the child is having breathlessness. Physical examination reveals there are diminished breath sounds on the left side of the chest, and there is a classical scooped out abdomen, which we even call it as the scaphoid abdomen at times, right? A chest x-ray has been given below, which you are able to see. They are asking you, based on the clinical scenario, what is the most probable diagnosis of the case? Let me know in the chat box. We know if a neonate or an infant has been brought to you after birth with complaints of breathlessness along with the scooped out and the scaphoid abdomen beta, we know it is a very classical case of nothing else but congenital diaphragmatic hernia, right? So the classical triad of congenital diaphragmatic hernia is remembered by RDS. R for respiratory distress, D for dextrocardia, that is heart is shifted to the right, and S for scaphoid abdomen. If you do a chest x-ray in patients of congenital diaphragmatic hernia, you are able to see the Bile loops in the thorax. This chest x-ray commonly shows us all the classical Bile loops in the thoracic cavity or in the thorax. So please tell me what is the classical case now. Please tell me what is the classical case. There are Bile loops in the thorax. ठीक है? So we know there are two cases of congenital diaphragmatic hernia which are given over here. One is option B, that is a Bogdalic hernia, which is a more common type, and next is option C, that is a Morgagni hernia. Both of them are types of congenital diaphragmatic hernia, but the basic difference, we know Bogdalic hernia is seen on the left side and in the posterolateral part of diaphragm. So please remember, Bogdalic hernia is on the left side and in the posterolateral part of diaphragm, whereas Morgagni's hernia is on the right side and in the anteromedial part of diaphragm. Morgagni's is basically seen on the right side and in the anteromedial part of diaphragm beta. Here you can see the Bile loops are basically in the left side of the thoracic cavity, whereas they have also said that there are diminished breath sounds in the left side of the thoracic cavity. ठीक है, तो diminished left sounds on the diminished breath sounds on the left side, that means the left lung is collapsed, and second, Bile loops are also seen in the left side of the thorax. So we know it is a classical case of the most common type called as option B, or a Bogdalic hernia. It is a classical case of option B, that is a Bogdalic hernia. We know whenever there is a case of a congenital diaphragmatic hernia, the Sarkari question, that what is absolutely contraindicated? We know that bag and mask ventilation is absolutely contraindicated because that will worsen the breathlessness in the child. And what is the airway of choice then? So if bag and mask ventilation is contraindicated, do remember the airway of choice is endotracheal intubation. ET intubation is the airway of choice in this patient. Hiatal hernia causes symptoms of GERD. It does not cause breathlessness like features commonly. ठीक है, scooped out abdomen वगैरह is not a common feature of the hiatal hernia. Gut atresia, it will cause bowel obstruction like features. Okay, no passage of meconium and all of that. ठीक है. Next is question number 63, which states we are having a neonate who was brought to the hospital with complaints of projectile vomiting after feeds. So after feeding the child, there is a projectile vomiting which is seen along with failure to thrive. The child is not able to gain weight and there is lethargy. They are saying that the child appears dehydrated and the palpation reveals a round lump in the epigastrium, or sometimes they can even describe it as a olive shaped lump in the epigastrium. Ultrasound abdomen has been done and it has been given below. What is the best treatment option they are asking you? So I hope all of you are quite aware, whenever a neonate is brought to you beta with complaints of projectile vomitings, especially after feeds, ठीक है, along with dehydration and olive shaped lump or a round lump in the epigastrium, I hope these itself are enough to diagnose it as a classical case of CHPS, that is congenital hypertrophic pyloric stenosis. Yes, it is a case of congenital hypertrophic pyloric stenosis, and as there is a hypertrophy of the pyloric canal beta, sorry, as there is hypertrophy of the pyloric muscles beta, you can see these are the hypertrophied pyloric muscles, and that's the reason why the pyloric canal becomes extremely narrow. And as the pyloric canal becomes extremely narrow, there is a gastric outlet obstruction which is going to happen. That is the reason why the child will have a projectile non-bilious vomiting, right? So CHPS, first of all, remember, important hint, CHPS happens due to intake of erythromycin by the mother during pregnancy. If the mother has taken erythromycin drug during pregnancy, that increases the risk of pyloric stenosis in the baby. We know that in pyloric stenosis there is a non-bilious projectile vomiting which is seen after 2 to 3 weeks of life, and there is a olive shaped lump which is there, and due to that vomiting child develops dehydration along with the metabolic disturbance, and that is a common question that they ask, what is the metabolic disturbance in pyloric stenosis? The metabolic disturbance in pyloric stenosis is hypokalemic, hypochloremic, hyponatremic metabolic alkalosis with paradoxical aciduria. ठीक है, तो hypokalemic, hypochloremic, hyponatremic metabolic acid alkalosis with paradoxical aciduria beta. And as there is dehydration and electrolyte disturbance, the first step in management of CHPS is IV fluids. The IV fluid of choice in patients of CHPS is half normal saline plus 5% dextrose plus minus KCl. Half normal saline plus 5% dextrose plus minus KCl. After, if that is not an option, then the answer is normal saline. This should be the best fluid. If this fluid is not an option, then the answer can be normal saline only. And the fluid that is absolutely contraindicated or avoided in patients of CHPS, answer is RL, that is Ringer's lactate. Ringer's lactate, if given, that worsens the metabolic alkalosis in the child, so do not give Ringer's lactate in a case of chronic vomiting or CHPS child. Clear? They are asking you what is the best treatment option for a case of CHPS over here. I hope all of you are quite aware. The best treatment option for a case of CHPS is option C, that is a Ramstad's pyloromyotomy. Right? It is a Ramstad's pyloromyotomy that we do. Heller's myotomy we discussed was the treatment of choice for achalasia cardia. Duodenojejunectomy can be done for duodenal atresia. Roux-en-Y gastrojejunectomy is basically done. Sorry, Roux-en-Y gastrojejunectomy, which is there, beta. It is usually a procedure that can be done for ulcers, right? So answer has to be option C, that is a Ramstad's pyloromyotomy. I hope all of you were able to get the answer right. ठीक है? Yes, right. Chalo. Next is question number 64. It states we are having a patient who had symptoms suggestive of GERD and the barium swallow was suggestive of a sliding hiatal hernia. On barium swallow, they were able to see there is a sliding hiatal hernia. So they have said that the patient has undergone the below given type of repair. So this is the type of repair that the patient has undergone. They are asking you to identify that which surgical procedure has been performed in this patient for a case of sliding hiatal hernia. I hope all of you are quite aware. In cases of hiatal hernia, the surgery of choice is usually a case of sorry, the surgery of choice is usually a fundoplication, and we know fundoplication can be of various types. The first one is going to be a Nissen's fundoplication. Do remember, Nissen's fundoplication is a complete 360-degree fundoplication when we plicate the fundus all around the lower esophagus. Next is Dors fundoplication. Dors fundoplication is a partial one, that is 180-degree anterior fundoplication. The Dors is a 180-degree anterior fundoplication. Third is a Taupet's one. Taupet's is a 270-degree posterior fundoplication. Taupet's is basically a 270-degree posterior fundoplication that we do. Okay? And Belsey Mark 4 is a 270-degree anterior, but that is not very commonly done in practice now. So you can forget about Belsey Mark 4. But remember the other ones. And here if you see this one, you can see there is a complete, that is a 360-degree wrap which is seen around the lower esophagus. You can see there is a complete 360-degree wrap of the fundus around lower esophagus, and we know complete 360-degree wrap is nothing else but option A, that is your Nissen's fundoplication, and that has been a repeated question in the FMGE or NEET PG exams. Recently NEET PG में भी this question came. ठीक है, so very easy, but ऐसा नहीं कि हर fundoplication Nissen's हो. Clear है बात? Do remember 270-degree posterior will be Taupet's and 180-degree anterior will be Dors also. But commonly they ask Nissen's in the exam. Next important is, we know Nissen's, if it is very tight wrap, it causes bloating also in the patient. Okay? Next is question number 65, some important flaps. So they are saying that below given flap will be used for which among the following condition. So if they ask you that this below given flap is used for which among the following condition, so I hope all of you are quite aware. If you see at the picture of the flap, यहाँ पे देख सकते हो, the flap is going to appear rhomboid shape. So you have raised the flap laterally and then you have brought the flap in the medial aspect, and you are covering the medial area medial area beta. So this is basically called as a rhomboid flap or a Limburg flap, and I hope all of you are quite aware this rhomboid flap or the Limburg flap is generally used in the perianal region beta. So in the perianal region we have a problem known as pilonidal sinus, also known as the jeep drivers bottoms disease. So we know that pilonidal sinus or jeep drivers bottoms disease के लिए there are multiple sinuses in the natal cleft. To cover those we have to use a rhomboid flap or a Limburg flap. So this like rhomboid or Limburg flap is generally used for the treatment of option D, pilonidal sinus beta. ठीक है. For perineal fistulas we do not use flaps, basically we go for a fistulectomy or a fistulotomy surgery. For anal fissure we basically go for a sphincterotomy surgery, not any flap. Anorectal malformations के लिए we commonly do an anorectoplasty. Clear? So another ones, definitely if they ask you, do remember the best treatment for a case of a pilonidal sinus is a Bascom surgery. Okay, the best treatment for a pilonidal sinus, if they ask you, this was a PYQ, the answer is going to be a Bascom surgery. But yes, apart from Bascom surgery we also tend to use the rhomboid flap or a Limburg flap as well for closure. Next important, if they ask you for breast reconstruction now, do remember for breast reconstruction the most common flap that we use is known as the tram flap. The commonest flap that we use for reconstruction of breast after mastectomy is the tram flap called as transverse rectus abdominis myocutaneous flap. Okay, transverse rectus abdominis myocutaneous flap or tram flap. Tram flap is the most common one, but it is not the best one. Reason, it has a high risk of hernia beta. It increases the risk of abdominal wall hernia. That's the reason it is not the commonest or it is not the best flap to be used. The best flap to be used for breast reconstruction surgery is the DIEP flap, that is deep inferior epigastric artery perforator flap. The best flap used for the breast reconstruction surgery is the DIEP flap, deep inferior epigastric artery perforator flap. So here you can see the flap has been taken from the patient's abdominal wall, and with the help of which you can see we have reconstructed the breast beta. That is what is known as the DIP flap. But yes, just by clinical picture it is very difficult to differentiate whether it is a tram flap or DIP flap, because both the flaps are taken from abdominal wall. DIP flap does not contain any muscles, so it does not make the abdominal wall weak and it does not increase the risk of abdominal wall hernia. ठीक है, तो इसीलिए most commonly used is tram flap, but the best one to be used is DIP flap. Next is this picture. This is the flap that is used after a oromandibular dissection. Whenever a patient had an oral cancer, after that we perform a commando surgery or a oromandibular dissection. After this commando surgery or oromandibular dissection, we use this flap commonly, and this flap you can see has been taken from the patient's chest wall. This flap that is taken from the patient's chest wall is classically called as the PMMC flap, that is pectoralis major myocutaneous flap. We call it as the PMMC flap, that is the pectoralis major myocutaneous flap beta. That is what is important. Hopefully clear. So these are the at least major flaps that you need to know. Okay, chalo. Next, if I talk about is question number 66, and the question says that a patient has presented to your clinic with the below given ulcerative lesion with raised everted margins over the burnt area. He gives history of burns 10 years ago. Okay, what is the probable diagnosis? This has been a PYQ and a commonly repeated image based question in the PYQs. So do remember, if they say patient is having a ulcerative lesion with raised or everted margins, and especially that too over a burnt area or over a burn scar, we know it is a very classical diagnosis of nothing else but option C, that is a Marjolin's ulcer. So recently I have shared a reel also basically regarding all the ulcers in a short. If you tend to forget, you can listen to that again and again. Okay? So do remember, here you are able to see beta, this is the classical ulcerative lesion in the shin which is having raised or everted margins, 1 point. And we know that Marjolin's ulcer is going to have a high risk, or it is commonly associated with squamous cell carcinoma. So Marjolin's ulcer is associated with squamous cell carcinoma, and as there is a risk of squamous cell carcinoma, we always do a biopsy whenever we diagnose a Marjolin's ulcer, because we never know whether it is a case of Marjolin's ulcer or it has already developed a squamous cell carcinoma. Therefore, a biopsy is necessary for diagnosing Marjolin's ulcer, and treatment is nothing else but wide local excision beta. Treatment for this case is nothing else but a wide local excision. For no other ulcer, you do a excision, but for Marjolin's, as there is a risk of malignancy, we do a wide local excision. समझे बात? तो raised everted cauliflower like edges, squamous cell carcinoma, okay, is a very classical feature of Marjolin's, commonly seen over a burn scar or chronic varicose veins में. ठीक है? If I talk about the other ones, the first one that you are able to see is a venous ulcer. We know venous ulcer are the superficial or shallow ulcers beta, and these venous ulcers are basically going to have the sloping edges. Along with that, these ulcers are commonly seen in the gaiters area of leg, that is above the ankle or above the medial malleolus. Very common PYQ it was, that what is the most common site of venous ulcer? Answer is gaiters area, and treatment is the Bisgard regime, right? Treatment is going to be the Bisgard regime, that is debridement, dressing, elevation, sorry, and elastic compression stockings. Next, the second picture which is there, it is a case of an arterial ulcer. If I talk about an arterial ulcer, and the third one is a trophic ulcer. So I hope all of you are quite aware that arterial ulcer and trophic ulcer which are there, they are somewhat similar to each other. So there can be a confusion which happens between both of them. So yaad rakhna one thing, if it is a case of an arterial ulcer or a trophic ulcer, one point is what? First of all, both of them are having punched out edges. Both of them are characterized by punched out edges. But do remember, arterial ulcers are commonly painful beta. So arterial ulcers are extremely painful, but on the other hand, the trophic ulcers are usually painless. Reason: arterial ulcers are usually associated with vascular disorders like atherosclerosis or Buerger's disease. So they cause an intense pain due to decreased blood supply. Whereas trophic ulcers are commonly associated with neuropathies, conditions like diabetes mellitus or leprosy. That's the reason as nerve damage happens. So these ulcers are usually painless in nature. Okay. Do remember, arterial ulcers mein treatment is revascularization and dressing, whereas in trophic ulcer the treatment is offloading. Okay, less weight should be there, so offloading, debridement and dressing again. Okay, so that is what is important. These are the points that has to be remembered for ulcers. Hopefully it is clear. Next is question number 67, a very common question which comes in the FMG examination, and that is, a patient presents to you with complaints of dysphagia along with halitosis and a swelling in the lateral aspect of the neck, which on pressing gives rise to a gurgling sound. So whenever you press the swelling, it gives rise to a gurgling sound, like this kind of sound is going to come. And I hope all of you are quite aware, whenever you press a swelling and that makes a gurgling sound, it is a classical Boise sign which is. And I hope all of you are quite aware now that Boise sign is seen in which condition, right? तो याद रखना Boyce sign is seen. So dysphagia, halitosis, regurgitation along with Boyce sign and the classical barium swallow image. As the patient is having dysphagia, we have done a barium swallow and that shows an outpouching from the esophageal wall. We know outpouching from the upper esophageal wall is usually a case of option D, that is a pharyngeal pouch, also known as a Zenker's diverticulum. The answer is nothing else but option D, beta, also called as pharyngeal pouch or Zenker's diverticulum. Yes, a lot of people are confused. What is pharyngeal pouch? So in a PYQ, they have mentioned pharyngeal pouch as the option instead of Zenker's. So याद रखना एक ही चीज है. Whether they say pharyngeal pouch or they say Zenker's diverticulum, answer is one and the same. We know Zenker's diverticulum or pharyngeal pouch arises from the upper one third of esophagus and it commonly arises from the Killian's dehiscence. So another question, what is the common site for Zenker's diverticulum? याद रखना, most common site for Zenker's diverticulum is Killian's dehiscence, especially between the thyropharyngeus and the cricopharyngeus muscle. Another PYQ. Zenker's diverticulum or pharyngeal pouch arises between the thyropharyngeus and the cricopharyngeus muscle fibers. That is important to be remembered. Clear? And we know for Zenker's diverticulum, investigation of choice is a barium swallow and treatment for a large Zenker's diverticulum is a Dohlmann's operation. If there is a large Zenker's diverticulum, usually more than 2 to 4 centimeters in size, then we have to use the linear stapler and perform a diverticuloesophagostomy. That is, remove the wall between the diverticulum and esophagus, and that diverticuloesophagostomy is known as Dohlmann's operation. We know laryngocele is a condition in ENT due to an abnormally dilated saccule, and that is going to have a Brice sign where when we press a swelling, hissing sound is heard like that is a laryngocele, and treatment for laryngocele is a surgical excision. I hope all of you are quite aware. Laryngocele usually starts with trumpet player. Barabar? Achalasia cardia, we know it may have dysphagia, it may have halitosis, but it does not have any kind of Boyce sign, and barium swallow shows you a bird beak appearance, not an outpouching. Skatsky ring is the case of dysphagia, but again barium swallow will show you basically a ring, fibrotic ring inside the esophageal wall, not a outpouching. Clear about? So that is important. Next is question number 68. It is a neonate has been brought to you with a congenital anomaly as depicted in the image below. Now they're asking you to identify that what is the likely anomaly over here. So I hope all of you are quite aware. This was a June 2021 FMG question. So here the investigation that they have given is a radiograph or an X-ray. But in this X-ray, the child has been held ulta. Okay, the child has been held upside down, ulta pakda bacche ko. So definitely this investigation is an invertogram. So whenever we suspect any kind of anorectal malformation or any kind of congenital anomalies in the anorectal region, we know we have to do a invertogram. ठीक है, so here definitely the diagnosis is some kind of anorectal malformation. That's the reason they have done an invertogram. Okay, and when we do a invertogram, I hope all of you are quite aware, we basically place some coin or the metallic marker at the estimated anal opening, and then we measure the distance between the metallic marker and the tip of gas shadow. If this distance is more than 2 centimeter, we know it is a high anorectal malformation. Agar gap zyada hai to high. If the distance is less than 2 centimeter, it is a low anorectal malformation. Gap kam hai to low. Do remember, invertogram is the first line investigation, but not the investigation of choice. Investigation of choice will be MRI only, and treatment will be a surgery called as anorectoplasty or a posterior sagittal anorectoplasty, we call it as. Clear है बात? अब मुझे बताओ, what is this anorectal malformation that you are able to see in the picture? What is this anorectal malformation seen in the picture? Yes, all of you are right. Answer is most likely option C, beta. That is a case of an imperforate anus. Matlab, the anal opening is not formed. And as the anal opening is not formed, we call it as imperforate anus, beta. That is the problem over here. Congenital megacolon, which is there. In those conditions, I don't need a invertogram first of all. I just take a X-ray abdomen. Second, congenital megacolon mein, there will be a distension of the bowel loops. But there would not be such a gap between the skin and the gas shadow. Clear hai baat? So congenital megacolon is Hirschsprung disease. This is not a case of Hirschsprung disease. Do remember that. Second is midgut volvulus. No, midgut volvulus basically beta will show me air fluid levels. due to bowel obstruction. ठीक है, midgut atresia, again it will show me air fluid levels itself. ठीक है, so that is important. Next important is question number 69, a very commonly repeated PYQ. Okay, so either from psychiatry or from the surgery the question comes. I hope all of you are quite aware about this. A young female patient was brought to you with complaints of chronic abdominal pain, and hence she was investigated further. She was taken up for a surgery and the below given finding was retrieved. This was the collection which was retrieved from her abdomen beta. Here you can see inside her stomach there was collection of hair. This hair has taken the shape of her stomach almost. So this is a large trichobezoar, right? Whenever there is collection of hair inside the GI tract, we classically call it as trichobezoar. And we know normal people though are not going to eat hair. So obviously this female is suffering from some psychiatric disorder. So this young female who is there, she is suffering from a psychiatric disorder known as trichotillomania, where she has a irresistible desire to pull out her own hair. वो खुद के बाल नोचती है बेटा, and after that she is going to eat those own hair. So trichotillomania में she pulls out her own hair and then she eats those. That is trichophagia. And due to that trichophagia, this collection of hair happens in the GI tract known as trichobezoar. Do remember, as she is suffering from a psychiatric disorder like trichotillomania, so they are asking you that this female should be referred to which among the following specialists. So after the surgery is done and after removal of the trichobezoar, we will definitely refer this female to option C, that is a psychiatrist beta. That is important to be remembered. Hopefully clear. Collection of hair is known as trichobezoar. Collection of sorry, collection of vegetable matter is known as phytatobezoar, and collection of milk or the milk substances is known as lactatobezoar. That has to be remembered. Okay? Yes. So please remember this. No issues with this. Chalo. Hopefully clear. Next is question number 70, and that states a young female patient presents to the casualty with complaints of right upper quadrant pain along with jaundice. Along with that, she is having fever, vomiting since the last 2 days. On examination, they are saying that a guarding there was guarding and Murphy's sign was elicited. Okay, I hope all of you are quite aware what is Murphy's sign. Whenever we palpate the right upper quadrant or the right hypochondrium, if there is severe pain, patient will catch his breath. Okay, that is when you palpate the right upper quadrant, दर्द के मारे पेशेंट अपनी सांस पकड़ लेता है या सांस रोक लेता है. That is what is Murphy's sign, right? So we know what is the likely diagnosis of the case that they are asking you. So here the patient is having right upper quadrant pain along with jaundice, along with fever, and a classical guarding and Murphy's sign most importantly. I hope all of you are quite aware that Murphy's sign is elicited whenever there is inflammation of gallbladder. That means it is a case of nothing else but option C, that is an acute cholecystitis. I hope all of you are quite aware it is a case of an acute cholecystitis. Acute pancreatitis mein patient will not have a right upper quadrant, but rather patient will have an epigastric pain radiating to the back. One thing, jaundice is less likely in acute pancreatitis, may happen if gallstones is the problem, so it may happen, but Murphy's sign is not elicited in acute pancreatitis. Next, perforation peritonitis mein guarding will be there. Murphy's sign is not a feature of peritonitis. Peritonitis mein patient definitely may have guarding, cardboard like rigidity, nausea, vomiting, shock like features. That would have been a case of perforation peritonitis. And for a case of perforation peritonitis, they should give you history of peptic ulcer disease or NSAID intake or trauma, something like that, right? So here there was no history, so why would we think about perforation peritonitis? Next, cholelithiasis or gallstones. No, cholelithiasis or gallstones may cause right upper quadrant pain, jaundice, but fever, vomiting, guarding, Murphy's sign, these are not the features of only gallstones or cholelithiasis. Due to that cholelithiasis, patient has developed acute cholecystitis. Due to that, these are problems. We know in cases of acute cholecystitis, investigation of choice is an ultrasound abdomen. Yes, ultrasound abdo is the investigation of choice, whether a cholelithiasis or a acute cholecystitis. Gold standard investigation for acute cholecystitis is HIDA scan. On HIDA scan, you are not able to see the gallbladder if it is inflamed. Okay, non-visualization of gallbladder is there if there is inflammation. So HIDA scan or hepatic immunodiacetic acid scan is the gold standard investigation. And treatment in cases of acute cholecystitis is conservative management. NPO, IV fluids, IV antibiotics, and analgesics. So conservative management is the treatment of choice. Do remember, If the patient came to you early, then you can go for an emergency cholecystectomy. But if the patient came to you late, then you have to go for a interval cholecystectomy. That is, you have to wait for a span of 4 to 6 weeks. So you have to remove the gallbladder, but it depends whether we should go for a emergency cholecystectomy or you should go for a interval cholecystectomy. That depends completely on the time of presentation. ठीक है. Here you are able to see an ultrasound classically showing you the posterior acoustic shadow. We know whenever an ultrasound shows us posterior acoustic shadow, we know it is a case of gallstones, that is cholelithiasis. So this is a classical picture of gallstones or cholelithiasis. Most common gallstones worldwide are mixed stones. Most common gallstones worldwide basically are going to be the mixed stones, whereas most common gallstones in Asia are going to be pigmented stones. Most common gallstones in Asia, we know they are going to be pigmented stones. That has to be kept in mind. Hopefully clear. Whereas if there is no posterior acoustic shadowing on the ultrasound, if there is no posterior acoustic shadowing on the ultrasound, do remember, then the diagnosis is going to be a gallbladder polyp. Whenever there is no posterior acoustic shadowing on the ultrasound abdomen, then it is a classical case of nothing else but gallbladder polyp. That has to be kept in mind. Now I want to ask you basically one question, that there are few more questions basically. So do you want to continue with the same session and finish off the questions? Do you want to end the one option is continue session and finish it off. Second option is continue like continue it tomorrow, but tomorrow I'll be able to continue only in the morning because in evening I need to travel. So tomorrow morning basically around 10 or 11 a.m. 10 or 11 a.m. I'll be able to continue it. A third stop over here, and this is it. Okay, so let me know basically, so what you want, so accordingly we can definitely take the decision. There are few more questions basically. That's the reason I don't want your sleep cycle to change. That's the reason I don't want your sleep cycle to change basically. That's the only reason. तो उसके हिसाब से बताओ. I'll count just a minute. चलो ना तुम्हारा ना मेरा one. Basically we will just do 5 more questions and then I'll call off for today. ठीक है. Okay, we will just do 5 more questions. तो जिनको continue करने का मन है उनका भी थोड़ा enthusiasm कम हो जाएगा, and those basically, ठीक है. हाँ, तो only 5 questions basically. For me tomorrow comes, so that's not an issue from my side basically. Chalo, I just don't want you to sleep very late and then get up later. Okay, so that should not happen. Your sleep cycle should not change because of me. So that is the only problem. Okay, so at least till 75 will do. Chalo. So here we are having question number 71 which states beta, there is a male patient who presents to the OPD with an abdominal lump in the periumbilical region. There is an abdominal lump in the periumbilical region which moves at a right angle to the attachment of mesentery. Okay, so we know this is the classical feature. One, a soft swelling or an abdominal lump in the umbilical or the periumbilical region. Second, the swelling moves at right angle or the swelling moves perpendicular to the mesentery. I hope all of you are quite aware. This is a classical feature of Tilloch stride, right? This is a classical feature of Tilloch stride, beta. So Tilloch stride is nothing else but one, there is a soft fluctuant swelling in the umbilical or periumbilical region. Second, swelling is mobile in perpendicular direction to the mesentery. And third, there is a zone of resonance around the swelling. There is a zone of resonance around swelling. So these three features are known as Tilloch stride, and that is seen in cases of mesenteric cyst, right? Whenever there is a cyst in the mesentery, okay, and the most common type of mesenteric cyst is a chylolymphatic cyst. Recent FMG question, though this was not expected, but it came. So chylolymphatic cyst, also known as a mesenteric cyst, beta. Okay, so there are multiple types of mesenteric cyst, but the most common type of mesenteric cyst we know is known as a chyliolymphatic cyst, where there is a lymphatic fluid collected inside the mesentery vita. And that is the condition where Thyroxstride is going to be seen. So answer has to be option B. Pancreatic pseudocyst mein they will give you a history of pancreatitis in the patient, and Thyroxstride is not going to be present in cases of pancreatic cyst. And in pancreatic pseudocyst, do remember the swelling is not seen in the periumbilical region. The swelling is basically seen in the epigastric region if it is a pancreatic pseudocyst. Clear? And it is not related to mesentery as such. Wilms tumor is basically a renal malignancy or a renal tumor seen in small children, and that is usually seen beta in the lumbar region or in the flank of the patient, not in periumbilical region, and not related to mesentery at all. Neuroblastoma is abdominal malignancy. Patient may have an abdominal lump, but that abdominal lump does not move with mesentery basically. So again, neuroblastoma is less likely. Investigation of choice for a mesenteric cyst or a chyliolymphatic cyst is a CCT abdomen, and the treatment is enucleation, which was the recent question. So in the recent FMG, when they asked a question, they asked you treatment for a chyliolymphatic cyst. So treatment of a chyliolymphatic cyst is enucleation, that is only removal of the cyst. If it is an androgenic cyst, then we do a resection and anastomosis. If it is an androgenic cyst, then we do a resection and anastomosis beta. But if it is a chyliolymphatic cyst, resection and anastomosis is not needed, just do a enucleation, that's it. So this is how the chyliolymphatic or a mesenteric cyst is going to look like. Hopefully clear about. Chalo. Question number 72, if I talk about here, they are saying we are having an elderly woman who presents to us with complaints of obstipation. We know absolute constipation is known as obstipation. Matlab, when the patient cannot pass stools as well as the patient cannot pass gas, that is flatus, that is known as an obstipation. The patient is having obstipation along with bilious vomiting, along with a crampy abdominal pain and abdominal distension. X-ray abdomen has been given below in the erect position. So X-ray abdomen erect view is given. What is the likely diagnosis? So we know whenever a patient comes to you with complaints like obstipation, constipation, vomiting, abdominal pain, and abdominal distension. All of these are features of bowel obstruction. We know bowel obstruction mein the first line investigation to be done is a X-ray abdomen. X-ray abdomen erect view will tell us obstruction is present or not. And X-ray abdomen in supine view will tell us about the site of obstruction. Okay, so erect view will tell whether obstruction is present or absent, and the supine view will tell what is the exact location of obstruction. So we know here you can see the X-ray abdomen erect view is showing you multiple air fluid levels. And we know whenever there are more than 3 air fluid levels on the X-ray abdomen erect view, whenever there are more than 3 air fluid levels on the X-ray abdomen erect view, we know it is surely a case of bowel obstruction. We know it is surely a case of bowel obstruction. Now, the funda is both the bowel obstructions are given in option. Option A is gallstone ileus, option B is small bowel obstruction, option C is toxic megacolon, and option D is large bowel obstruction. First, we know gallstone ileus can be ruled out. Reason, gallstone ileus mein bowel obstruction happens, but apart from bowel obstruction, X-ray will also show you the other features like the regular stride is going to be seen if it is a case of gallstone ileus. We know what is the regular stride in gallstone ileus. Gallstone ileus matlab the gallstone is basically causing a bowel obstruction. So when a gallstone causes a bowel obstruction, we call it as gallstone ileus, and there is a regular stride, that is air inside the gallbladder. We know air inside gallbladder is known as pneumobilia. Second, air fluid levels suggestive of small bowel obstruction. And third, you are able to see a gallstone or a shadow of a gallstone in the right iliac fossa. So do remember pneumobilia, small bowel obstruction, and gallstone. These are the three features of regular stride that is seen in gallstone ileus. यहाँ पे air fluid levels तो दिख रहा है, but there is no pneumobilia, no gallstone. So we cannot call it as a case of a gallstone ileus in this one. Small bowel obstruction, yes, it is a diagnosis of small bowel obstruction. Reason, multiple air fluid levels are seen, and secondly, if you see the diameter of the bowel loops, these bowel loops appear to be small only, and secondly, they are in the center. Whenever the distended bowel loops are usually smaller in size, and if they are in the center. Third, you can also see slightly the step ladder pattern somewhat. Okay, not very clearly though, but yes, somewhat the step ladder pattern can be seen. So we know it is a classical case of small bowel obstruction. Obviously, the X-ray abdomen supine view will confirm it further, but more likely it is a case of small bowel. Large bowel obstruction hota, so the distended bowel loops would have been in the periphery, first thing. Second, the diameter of the loop would have been large, And third, it would have shown us hostrations beta. Nothing of that kind is seen over here. Toxic megacolon mein, the bowel is absolutely grossly dilated beta. So whenever the bowel is going to be grossly dilated, as you can see over here in the picture, severe dilatation or severe distension of the bowel loops, that is known as toxic megacolon. And I hope all of you are quite aware, toxic megacolon is commonly associated with ulcerative colitis. So here you can see the diameter of bowel loop. It is so big, right? So this is a picture of toxic megacolon commonly associated with ulcerative colitis. Hopefully clear. Question number 73. Here, another question related to bowel obstruction itself. They are saying a patient presents to you with complaints of severe abdominal distension after an abdominal surgery. Yes, so we know during a surgery there can be a bowel handling, and due to that bowel handling beta, after the surgery for few hours or few days, patient may have sorry, no motility in the intestine or no motility in the GI tract, right? But sometimes definitely the motility does not return, and if the motility does not return timely, the patient will develop this problem. What is the diagnosis? Let me know in the chat box. So there is a severe abdominal distension after an abdominal surgery, abdominal distension after abdominal surgery. X-ray abdomen reveals there is a bowel obstruction now. So if they say, okay, after abdominal surgery, there is a bowel obstruction, especially an adynamic bowel obstruction. What is that condition? Let me know in the chat box. What is the most likely electrolyte disturbance which will lead to this condition? So I hope all of you are quite aware, beta. The diagnosis in this case is classically a case of nothing else but, yes, beta. The session will be there on YouTube. Basically, don't worry about that. The provisional diagnosis which is there, it is nothing else but a case of paralytic ileus. We know after surgery, whenever the motility of the intestine does not return timely, there is an adynamic bowel obstruction, and whenever there will be an adynamic bowel obstruction, the patient will develop a problem known as paralytic ileus, right? So adynamic bowel obstruction basically called as paralytic ileus, and whenever there is a paralytic ileus, patient will have problems like constipation, obstipation, vomiting, distension, but pain is not usually seen. The commonest cause for a case of a paralytic ileus is surgery. The most common cause for a paralytic ileus is surgery, and we know the most common electrolyte disturbance. This was a PYQ. The most common electrolyte disturbance is going to be option A, that is hypokalemia. Most common electrolyte disturbance causing paralytic ileus is option A, that is hypokalemia. Do remember, hyperkalemia, hypermagnesemia, hyponatremia, they do not cause any kind of paralytic ileus. Most common cause is surgery, and most common electrolyte disturbance is hypokalemia. Treatment is nothing else but we just have to treat the electrolyte disturbances. Once you treat the electrolyte disturbances, beta, the condition gets resolved automatically. Clear? Next is this case where they say, while performing an appendectomy, okay, while performing an appendectomy or appendicectomy, the surgeon notices a given lesion which is 2 feet proximal from the ileocecal junction. So there is a lesion which is 2 feet proximal from the ileocecal junction. Okay, what is the likely diagnosis? I hope all of you are quite aware. During an appendixectomy, if you find this kind of a lesion which is 2 feet proximal from the ileocecal junction, and it appears as a outpouching from the bowel or outpouching from the gut, we know it is a classical case of nothing else but, let me know, we know this problem which is there, it happens due to the persistent vitelline duct. We know if the vitelline duct or the vitellointestinal duct does not disappear, if the vitelline duct or the vitellointestinal duct does not disappear, that can lead to this outpouching, and this outpouching is classically known as option D, that is a Meckel's diverticulum beta. We know Meckel's diverticulum which is there, it is going to follow the rule of 2, and the rule of 2 followed by Meckel's diverticulum says it is seen in 2% of the population, it is going to be 2 inches long, it is 2 feet proximal from the ileocecal junction. Okay, so 2% population, 2 inches long, and 2 feet proximal from ileocecal junction, that is a Meckel's. In Meckel's, sometimes there can be an ectopic mucosa, and PYQ was most common ectopic mucosa. Do remember, most common ectopic mucosa in Meckel's diverticulum is gastric mucosa. And investigation of choice is nothing else but technetium 99 per technate scan. So technetium 99 per technate scan is the investigation of choice for Meckel's diverticulum. Do remember this point. We know intersusception which is there, it will present to you with complaints of bowel obstruction. Okay, and in intersusception there is not an outpouching, there is invagination of one loop into another. Clear about? And do remember, intersusception does not happen 2 feet proximal to ileocecal junction. Commonly it happens at the ileocecal junction itself. Okay? Ileocecal tuberculosis, again it happens commonly at the ileocecal junction, and it does not form any outpouching. Either it forms ulcers, transverse ulcers we know, or it is basically known to cause mass. Diverticulitis, it is commonly seen in elderly patient, and there are multiple outpouchings in diverticulitis which will cause bleeding. That is the important thing. Okay? And treatment we know, in patients of Meckel's diverticulum, if the Meckel's diverticulum is narrow, we go for a treatment that is diverticulectomy. So if the Meckel's diverticulum is basically narrow, then we go for a treatment that is known as diverticulectomy. If the Meckel's diverticulum is wide, we don't need to go for a diverticulectomy. If the Meckel's diverticulum is wide, we don't perform a diverticulectomy. Do remember that. And here, this is the picture of a case of an ileocecal TB or an intestinal TB. We know whenever a patient is having ileocecal tuberculosis or an intestinal tuberculosis, this is the feature that is seen. Okay, we know in ileocecal TB there is going to be this classical pulled up cecum that you are able to see in the picture, along with a goose neck or a swan neck deformity. So a classical pulled up cecum along with a goose neck or a swan neck deformity, if it is seen, it is a case of an ileocecal TB or an intestinal tuberculosis that has to be kept in mind. And treatment is ATT as usual. And last question today we'll discuss, and that is this. Here we are having a newborn who was brought to you few hours after birth. A newborn who was brought to us few hours after birth, basically with complaints of bilious kind of a vomiting, that is a greenish vomiting which was seen. Okay. Now they are saying X-ray abdomen has been done and it reveals the given finding. What is seen? You are able to see two bubbles beta. Instead of one, you are able to see two bubbles. That is a double bubble sign. We know double bubble sign which is there, it is seen in two conditions mainly, rather three conditions we know. One is duodenal atresia, second is annular pancreas, and third is Lat's band. I have told you in class also that double bubble sign is usually seen in three conditions. One is duodenal atresia, second is annular pancreas, and third is Lat's band. Important is, यहाँ पे if you see the double bubble sign, more likely it will be a case of duodenal atresia or annular pancreas. Let me know. Both are in the option. We know pyloric stenosis cannot be the diagnosis over here. Reason, pyloric stenosis or CHPS के cases में we are just able to see a single bubble sign on the X-ray abdomen. If the X-ray abdomen shows you the single bubble sign, then the diagnosis is basically going to be a case of CHPS or pyloric stenosis. So CHPS or pyloric stenosis में there is a single bubble sign seen on X-ray abdomen. Hopefully clear. Jejunal atresia cannot be a jejunal atresia cannot be a diagnosis because it is going to have the classical triple bubble sign. So if it is a triple bubble sign on X-ray abdomen, then we think about jejunal atresia. So either it is duodenal atresia or it is annular pancreas. Very good. Answer would be a duodenal atresia. Reason beta दो चीज है. First of all, incidence wise duodenal atresia is common. Second important, in duodenal atresia we have a bilious vomiting beta. We have a bilious vomiting or a greenish vomiting. Whereas in annular pancreas commonly there is a non-bilious vomiting. There can be bilious, but more commonly in annular pancreas there is a non-bilious vomiting. Clear? Because there is obstruction of the second part of duodenum by the annular pancreas. That's the reason commonly it is non-bilious vomiting. इसीलिए ठीक है. तो investigation of choice for duodenal atresia, तो answer is duodenal atresia for this case. And the investigation of choice for duodenal atresia beta is nothing else but CCT abdomen. And treatment is, we should definitely go for a duodenostomy. So both the ends of the duodenum which are not connected with each other, you should connect both those ends together. That is duodenostomy. And if the gap is too much, then you should go for a DJstomy or a duodenostomy beta. ठीक है. Chalo, so thank you so much. Thank you for being patient throughout the session. ठीक है, and thank you for being active in the session as well. ठीक है. Hopefully you have gained confidence after this session, बच्चे. Not gastrojejunostomy, भाई. ठीक है. चलो. And good night. Take care. So tomorrow, do you wish me to continue? Basically, if it is too late right now, so we can continue at 11. I hope maximum it would be 1 hour ka session that would be left, 1 or 1.5 hour maximum. ठीक है. चलो. So I'll align a session basically at 11 a.m. tomorrow. Hopefully it would be fine for all of you. Okay. The total 100 questions, so 25 questions are remaining, but the other ones, the latter ones that I've included are less important or less expected. ठीक है? So that's the reason those are मतलब one liner type questions थोड़ा बहुत, तो इसीलिए they will be much faster. चलो बच्चे, ठीक है? Take care. Thank you so much and good night. ENT के लिए let me try basically because I need to travel tomorrow, so I'll inform you about ENT. I'll share the PDF right away. Don't worry about that. In my Telegram group, you can check. You'll get the PDF over there. ठीक है? चलो.